honorable scholars, and experts, and all the participants, whether in person or virtually. Welcome to today's 10th Tzu-Chi Global Symposium for Common Goodness. Our topic today will be focusing on chaplaincy in medical services. First, let me introduce our distinguished guest, Dr. Junlong Lin, CEO of Buddhist Tzu-Chi Medical Foundation. Dr. You-Chen Chao, Superintendent of Taipei Tzu-Chi Hospital. Welcome. Dr. Su-Yong Park, Vice President of Academic Affairs and Dean at Union Theological Seminary. Professor Kosen Gregory Snyder, Senior Director and Assistant Professor of Buddhist Study at Union Theological Seminary. Dr. Rey-Sheng, Deputy CEO of Tzu-Chi Foundation. Dr. Tzung-Jeng Hwang, Chairperson of Buddhist Lotus Hospice Care Foundation. Dr. Ming-Nan, Vice Superintendent of Dalin Tzu-Chi Hospital. Dr. Heng-Chia Chang, Vice Superintendent of Taipei Tzu-Chi Hospital. Dr. Ying-Wei Wang, Director of Palliative Care Center at Hualien Tzu-Chi Hospital. Venerable Master Zong-Dun, founder of Taipei Academy. Laura O. Laughlin, co-founder of Brooklyn Zen Center. Wang, Director of Buddhist Lotus Hospice Care Foundation. Qingfang Zhen, Director of Communication with Humanity Office at Buddhism Tzu-Chi Medical Foundation. Pei-Ying Lin, Assistant Professor at Graduate Institution of Religious Study, National Zhengzhi University. Welcome. Welcome, everyone. So first is our open remarks. Let's welcome Dr. Junlong Lin for open remarks.
Professor Snyder, Professor Park, Superintendent Chao, and all the distinguished guests. Thank you for coming to participate to this wonderful event. As you know, palliative care has been a sort of main thing in running of our hospitals. We Tzu-Chi hospitals was founded basically some almost 60 years ago by Master Chen in Hualien. She later opened the hospital in Hualien some 37 years ago, a long time ago. But she insisted that we take care of our patients, not only professionally, but also humanistically. In the process of delivering medical care, how do we deliver or show our caring and love in the process? And this is very important to our organizations. We have now 8 hospitals, and this is one of them. Taipei branch is one of the 8 hospitals around the island of Taiwan. And again, we provide top-notch medical services professionally. However, we also provide tender, loving care to our patients. That is, the humanistic area is very important in our medical care, in our hospitals. Now, when it comes to hospice care, when all the active medical management has sort of come to an end, the humanistic aspect of the care becomes very important. Therefore, we have Dr. Wang, Dr. Lin, they are basically family practitioners by their medical training, but they look into this area of hospice care and provide that additional care that is needed for this type of patients, because most patients in other areas of the hospital, they are looking forward to speedy recovery. However, in hospice care, they cannot expect speedy recovery. So they have to face the natural causes of a disease. And finally, they have to face the final call. Therefore, it's very important for our hospitals, for our 8 hospitals around the island, besides provide acute medical care, we concentrate quite a bit on this area of terminal care, so to speak, hospice. But that doesn't mean that we give up everything. There means we combine with the palliative efforts of medicine, such as pain relieving, say for instance, and other areas that we can provide comfort to our patients. And this is really important. But in addition to that, besides medical care and providing of this comfortable environment, the spiritual area is additional area that we sort of concentrate on. The patient might have different religions, different beliefs, especially in Taiwan, you know. They believe in the traditional area. They are not necessarily Christian or Buddhists, and they believe in their own sort of areas that we might not even know about. But they are pretty much the same. You have to go on what they have in their beliefs and try to relieve their anxiety, their discomfort in going through the process. So that is not an easy task. However, our people are doing a very good job. Later you can hear what they do in this area. So this is the area that really is important for our patients when they reach this stage of their course of the disease. And we're trying our best to provide. Again, the same principle. Whatever the patient needs, we try to provide it in such a way, with tender, with loving, and with our sincere hope that they will get comforted, they will go through the process very comfortably, naturally, and also successfully. So today, we welcome the people from abroad and the people from Lotus Foundation. Our friends, we used to go with past presidents that we hand in hand. There is a training course for this area of work. And hopefully, we'll learn a lot more from our visitors, and then we can put it into practice in our hospitals. This is what we are really expecting. And thank you for coming to Taiwan, to our hospitals, and share with us your experiences and see what else we can do to improve our care for our palliative care units, our patients as well. Thank you again, and hope you enjoy your stay. And hopefully our hospitality to you, and also our environment and our work is up to your standard. And please tell us if there's anything we can improve and anything we can do to improve our care for our patients. Thank you.
Thank you, CEO Jin Longling. Let's invite Dr. You-Chen Chao for the open smart remarks.
Distinguished guests, Professor Park, Professor and Mrs. Snyder, CEO Lin, and Dr. Hwang, and all participants, good morning. On behalf of Taipei Tzu Chi Hospital, I'd like to express our heartfelt gratitude to all the participants, because the chaplaincy in medical services is a so important topic in the hospital. As I said before, love is the best medicine in the world, but I think chaplaincy is also the same meaning as love. Today, I'd like to invite our Vice Superintendent, Heng-Chia, to present how we perform the chaplaincy in our hospital. I think not only doctors and the nurses, but also the volunteers in the hospital all are chaplain to patients. Not only cancer patients, every patient in the hospital, they are fighting for the disease, fighting for the virus, bacteria, cancer as well. They are not suffering pain, but also suffering fear. So I think today, chaplaincy and the Buddhist training is very, very important. So thank you again, and hope this conference is very successful. Thank you again. Thank you.
Thank you, Dr. And before we move to the keynote speech, let's give another welcome for the distinguished guests and the Lotus Buddhist Hospice Foundations, also all the volunteers that joined today's event. And also, like we are going to take a group photo. So we're waiting for our cameraman. So for the guys by the side, please move towards your body a little bit towards the middle, so that your face and your body will be presented in really good in the photo. Also, you can take your mask off, so you can see your smile on the face. Okay, so, oh, okay. Yes?
Okay, smile.
That's the
1, 2, 3. One, 2, 3.
One more. Good. Thank you for all your patience for the group photos. Okay. So for our first keynote speaker, Dr. Park, her life and research passion including contemplative practices, chaplaincy education, the elderly and spirituality, women's leadership, and integrative, embodied, and critical pedagogies in the last decade, Dr. Park, a lifelong Presbyterian, turned towards Buddhist practice in Thich Nhat Hanh Palm Village tradition. She is a spiritual director grounded in contemplative traditions. Her topic today is a chaplains as meaning makers. Let's welcome Dr. Park. Please come to the stage.
Thank you. I want to first thank the Tzu Chi Foundation, Dr. He, CEO Lin, and our esteemed colleagues gathered here for this wonderful opportunity to learn and share wisdom together across geopolitical national boundaries. I believe that this kind of wisdom sharing across cultures and contexts is crucial for understanding this emerging field of chaplaincy studies. And I bring greetings from Union Theological Seminary on behalf of the President Serene Jones. She is delighted that Professor Snyder and I are visiting and learning from the Tzu Chi Foundation and exploring possible partnerships and collaborations. Over the last few days, we've had the privilege to witness and learn about this inspiring work of Tzu Chi. And I see the urgency of providing spiritual care alongside humanitarian aid, medical services, and education. I look forward to our conversation together this morning. So before I begin my formal remarks, I want to first contextualize my work. Working with chaplains and students training to be chaplains in a primarily Christian context of the United States, I recognize the difference in the approach and the religious framework in which this education takes place. Union Theological Seminary is historically a Protestant seminary with deep roots and ethos of Christianity that values justice commitments, which also pervade the curriculum and the culture of the institution. And even with the good work of my colleague here, Professor Snyder, who teaches Buddhist studies, and Professor Jerusha Rhodes, a professor of Islam, our institution struggles with what it means to train Buddhist chaplains through the container or framework of interreligious engagement in a historically Protestant seminary. So I want to first name that reality. The faculty and the board as a whole is committed to this move towards interreligious engagement and would like to see the study of Buddhism, Islam, and other religious traditions not as an additive to the Christian-centered curriculum, but as an interstitial connective tissue that invites the exploration of how religious traditions are formed and changed as they come in contact with each other. As such, I invite other presenters here this morning to engage my presentation from your own contexts and perspectives, and maybe perhaps explore together the resonances, the differences, and how we might create new interstitial connective tissues in the field of chaplaincy education and chaplaincy studies. While an academic discipline of, say, pastoral theology or spiritual care and counseling has been firmly established in the US, the field of chaplaincy as a discipline of study is fairly new. In the last decade, there has been a concerted effort by interdisciplinary scholars of spiritual care, practical theologians, sociologists, medicine and health researchers to advance the research methods in chaplaincy and to promote religious literacy among healthcare professionals. George Fitchett and Wendy Cadge are two such leaders in this work. And organizations like Transforming Chaplaincy and the Chaplaincy Innovation Lab have taken up the task of bringing together chaplains, chaplain educators, and researchers to create a central hub to understand the emerging and rapidly changing landscape of chaplaincy. The shape-shifting and expanding nature of chaplaincy requires us to pay close attention to how chaplaincy manifests itself, especially in the US. And I invite you to consider your own context of Taiwan and Tzu Chi worldwide to see if there are connections. In the US, as chaplains become more diverse in terms of religion and worldviews, so too the contexts where they work. There are chaplains at the airport, college and universities, fire and police departments, prisons, hospitals, hospices, nursing homes, social service agencies, family services, military installations, labor unions, businesses, seaport, racetracks, truck stops, movement spaces like Occupy Wall Street, Black Lives Matter, and Standing Rock, and on online and mobile app like Venly. As an aside, I am thinking about protest movements in Asian contexts, like the nonviolent candlelight vigils in South Korea in 2017 that demanded the impeachment of President Park Geun-hye, or the yellow umbrella movement in Hong Kong that demanded fair and free elections. And it made me wonder if there were movement chaplains involved and present in those protests. In addition, the COVID-19 pandemic has brought chaplains to the front line of the battle in ways that demystify their roles and made them highly visible. In 2020 to 2021, many news outlets covered stories about chaplains, their work, their commitments, and their lives as the pandemic altered how people were cared for, died, processed grief and loss, and ritualized death. The chaplain's role, along with healthcare professionals, was at the center of the pandemic. Chaplaincy has become one of the most sought after concentration for study for students at Union since then. The changing nature of chaplaincy is both the product of and the impetus for the changing religious landscape of the United States. With an increasing number of Americans claiming spiritual, not religious, or nuns or duns with organized, institutionalized religion, chaplaincy is changing in response to the larger movement to reorganize religious life as we know it. More people are seeking spirituality outside of the institutional faith communities, bringing religion into public and often secular spaces. However, within the spaces that traditionally might have been regarded as secular, many are seeking deep spiritual heritage and training and connection. The current embodiment of spiritual practice regularly defies the traditional categories of religious heritage. Navigating this often conflicted space, chaplains have become, and I quote, the priests of the secular, or 21st century's indispensable ministers without portfolio. And currently, chaplaincy in the US is developing in two seemingly conflicting directions. First, in an effort to move towards professionalization, standardization, and certification, chaplaincy is becoming more regulated by the state via degree and certificate granting bodies. Secular institutions in which chaplains work are likewise highly regulated. Religious traditions engaging chaplaincy in the US are increasing, complicating the formal process of training and certification. So what does the increasing interreligious complexity of chaplaincy education mean when many of the assumptions in the professionalization, standardization, and certification process remain mainly, at least culturally, Protestant Christian? Second, chaplaincy is proliferating in new contexts previously unimagined, such as protest movements like, as I mentioned earlier, Black Lives Matter or Standing Rock. In these contexts, chaplains are organized on an ad hoc and temporary basis through organically and more loosely formed networks and through social media. These movement spaces are also becoming deeply interreligious. Chaplains varying training is democratizing chaplaincy in a way. And while all the competencies of skillful, trauma-informed chaplain are needed in these fast-changing and turbulent spaces, there is no certifying body that credentials such chaplains. That they are highly unregulated raises further questions about effective forms of education. So as regulators, how do we maintain the standards so critical to accountability while creating space for new forms of chaplaincy to emerge? As professional colleagues, how do we support the solid work of traditional chaplaincy and incubate experimentation like chaplaincy through mobile apps? As educators, how do we create a pedagogy that allows so many meaningful religious differences to endure while cultivating the possibility for connections across those differences? In this emerging territory, how do we take seriously all these connections and provide a formal education that lays a foundation for this work? And such questions inform Union Theological Seminary's Master of Divinity program that aims to train chaplains in general and Buddhist chaplains in particular with the interreligious perspectives, interpersonal, self-inquiry, spiritual care, justice commitments, and meaning-making competencies necessary to flourish in this quickly changing world. So allow me to reflect briefly on the COVID-19 pandemic experience in New York City, which in some sense feels like eons ago, and yet a sense of doom and gloom still lingers. It haunts us. And I want to quote from an opinion piece in the New York Times by reporter Barry Weiss, dated April 3rd, 2020. You may remember this is when New York City was deep and thick in the paralysis of contagion, sickness, and death. This was when 8.5 million New Yorkers were afraid to go out, talk with neighbors, connect with family and friends, and even to breathe. Barry Weiss starts her piece this way. Few run toward the dying. Even fewer run toward the contagious. But chaplains do. They minister to the sick before this pandemic turned their hospitals into war zones. And they will do so after this plague subsides. Doctors and nurses focused on healing the physical. Chaplains are there for everything else. They are men and women from every religious background and none. Their job is not to convert or to convince people to believe in God. Some don't believe in God. Their job is to be present with people in their suffering. Theirs is a ministry of presence. The essential work of chaplaincy remains the same, to facilitate connection between patients and doctors, patients and families, patients and God. Chaplains run toward the dying. Chaplains run toward the contagious when everyone else flee. Chaplain run toward suffering. they respond to suffering. The fact that they respond is the impetus that drives all helping professions. And the work of the chaplain is not just in the doing, but also in the being and reflecting. The doing has to be followed by deep, prayerful, thoughtful analysis and reflection so that their doing can improve. The non-linear, circular movement of praxis, action, reflection, action, forms the facilitating connective work of chaplains. This work helps to make meaning in the face of random and sudden trauma or disaster. One of the chaplains quoted in that same New York Times article said, "I actually think that when people are in their most broken places, they have the most honest conversations, and they're most open. Their hearts are open. Their families are open. Sometimes pain brings people together." And this is the meaning-making work of chaplains. So to explore this meaning-making capacity of chaplains, I use Richard Osmer's four-question frame of practical theology. 1, first we ask, what is going on? That's the descriptive task. And we might ask, why is it going on? The interpretive task. What should be going on? The normative task. And finally, how do we respond? The pragmatic task. While they seem to be in chronological and linear order, in real life and real time, these questions overlap and circle back on each other. So what is going on can often be interchanged with why is it going on and what should be going on. But it is helpful as we discuss this to tease out these questions as we listen to those who seek our care. So this is a heuristic. This is one way of listening to people who are asking for our care. These 4 things. What is going on? Why is it going on? What should be going on? And how do we respond? So I will be framing the rest of my presentation with these 4 questions. What is going on? The descriptive task here. Carrie Doring, in her work, The Practice of Pastoral Care, a Postmodern Approach, frames the work of spiritual care in a narrative approach. In this approach, spiritual care begins with, and I quote, "a stepping respectfully and compassionately into another's narrative world," and develops by mingling the care seekers and caregivers' narrative world that generates an intersubjective space for meaning making. In other words, entering into narrative world with each other helps facilitate meaning making. With compassion and hospitality, the caregiver is invited, and caregiver I mean the chaplains are invited to enter into care seekers' narrative world. Through this inherently relational process, both parties, chaplain and the care seekers, are changed. The intersubjective space is where meaning and wisdom are co-created, created together between the chaplain and the care seeker out of the intermingling and braiding of care seekers and caregiver stories, spoken and unspoken. So this intersubjective space is created through deep and respectful listening of not only the words, but of body language. They listen not only with their ears, but also with the ears of their heart, as they attune to what is being communicated somatically. Is there stress, anger, sorrow, or calm? Also, by matching the posture and tone of voice to that of care seekers, chaplains signal that they're being seen and heard. In times of crisis, when care seekers are overwhelmed with emotion, chaplains practice non-anxious presence through their voice and posture to communicate a sense of calm, and confidence. It de-escalates the intensity of emotions. And through grounding practices, chaplains too learn to calm their own nervous systems so that they can communicate a sense of calm and safety to those who they serve. In doing so, they establish resonances with the care seekers, which is foundational for the ministry of presence, creating a sense of safety, trust, and connection. Why is it going on? This is the interpretive task. Consider this quote by Ibu Patel. A narrative identity is a careful selection and stringing together the moments and events that matter for a particular purpose. It's an act of intentional interpretation and meaning making. There is a selection going on here, and there is a purpose or goal for that selection, and there is intention. It's not accidental how we curate our identity. We curate moments and events that matter to construct meaning and thus an identity. We interpret life events. We cultivate capacities for understanding what is happening. This is fundamental to being human. We use symbols, stories, rituals, and traditions to make meaning. We filter our meaning through our contexts and meaning-making systems, whether they are cultural, religious, or ideological. The descriptive task of what is going on in conversation with the normative task of what should be going on is instructive. So for example, when the practice is wrong, norms can correct and guide the practice. When the norms are reified, the practice can disrupt and interrogate the norms. They are dialogically related. So as chaplains, we help care seekers understand how their emotional reactions to shame, fear, guilt, and anger hold together the meaning-making system formed in childhood by family and social systems and accompanying values, beliefs, and ways of coping. And we ask the question, is it life-giving or is it life-limiting? If it is life-limiting, how might the chaplain compassionately and collaboratively highlight the destructive power of the life-limiting meaning-making system and accompany the care seeker toward liberative exploration? How might the chaplain remind the care seeker of the life-giving resources that the care seekers have access to and accompany them in that exploration? So chaplains listen carefully to assess the level of spiritual distress. Kenneth Pargament developed the criteria to assess positive and negative religious or spiritual coping. Many coping mechanisms are not readily conscious. They have been formed by our culture, religious and spiritual traditions, familial and community contexts. They are implicit, they are embodied, they are habituated, and escape our rational, logical mind. So it is through careful, deep listening that chaplains are able to assess how the care seeker is coping in crisis. Here are some key themes to listen for. Sense of connectedness to the sacred sources of spirituality. We listen to the care seekers with these questions in mind. Is there an anchor beyond themselves? Do they have a religious or spiritual community that can support their coping? Do they have practices, texts, art, and music or other ways of engagement that they turn to when they're in crisis? How do their sacred texts and traditions help them in their distress and shed light in the meaning in their lives? How have they helped in the past? How might they help now? 2, sense of connectedness with family, friends, and social world. We listen with these questions in mind. What are the key relationships for this person? Do they have communities they belong to that offer a sense of belonging and meaning for their lives? how do these communities show up as we listen to the stories they tell as they make meaning of their lives? 3, sense of values and how these values provide orientation, determine goodness and truth in the person's life, and guide their choices and actions. So we listen with these questions in mind. What does a person value most? How does the care seeker's life reflect those values? Are there congruences? And 4, a level of risk of harm to self. For all helping professions, it is important to be skilled in screening for suicide assessment and other self-harming behaviors. Do they have a history of self-harm or thoughts of self-harm? If so, how regularly do they have these behaviors? While a chaplain's main responsibility is to assess how spiritual coping either increases or decreases the risk of self-harm, listening for purpose, meaning, and sense of belonging in life are key spiritual indicators of assessing suicide risk. Now, how do we respond? This is a pragmatic task. What do chaplains do as meaning makers? I want to explore how they respond in 3 concrete ways. 1, meaning making in liminal and transition times and spaces. 2, meaning making in face of suffering. And 3, meaning making in pluralistic society. So first, meaning making in liminal and transition times. While meaning making often happens in sharing our stories, such as listening to the narrative identity we have curated for ourselves, during liminal, transition, and boundary situations, rituals have the efficacy and power to provide the stability, mark sacred time and space, remember and reveal, nurture resiliency, and empower and inspire new visions of freedom from affliction. In these liminal moments of life transitions like birth, significant birthdays, marriage, death, adoption, divorce, leaving home to attend school, graduations, and boundary situations like entering into a new relationship, receiving terminal illness diagnosis, begin caring for aging parents, and other such situations, chaplains are called to offer rituals to help make meaning during those liminal and boundary spaces. Secondly, meaning making in face of suffering. Some psychological research on suffering distinguishes suffering from pain. They say suffering is pain that is not understood, not comprehended. Pain that has no perceived meaning leads to suffering. I would nuance this to add that the pain that is comprehended through a life-limiting meaning-making system that leads to even more attachment and grasping would lead to more suffering. So meaning-making needs to disrupt our fixation on pain and not reinscribe it as essential identification of the person. Suffering can also arise when there is a rupture of meaning, when the understanding of oneself, community, and world is shaken up by crises, traumatic, and randomly unpredictable events. Life seems meaningless. And people ask why questions in the face of life's fragility. And in oppressive, humanizing systems like the prison and living in poverty, there is a slow grounding down of that thus destroys a sense of self, belonging, and purpose. This also leads to suffering. I was giving 3-minute notice. I'm going to read a little bit fast. Chaplains in these spaces of human suffering are witnesses to what is and witnesses to what it can be with renewed meaning and purpose toward healing and liberation. They listen for stories, practices, symbols, values, beliefs that undergird the stories that are told. They diagnose spiritual distress that is experienced when meaning-making system gets stuck and fragmented. And through attentive and compassionate listening, the care seekers can begin to reconstruct new meaning, reclaim sense of urgency, agency, and identity. This is my last point, and I'll wrap it up. Meaning making in a pluralistic society. Chaplains are called upon to provide spiritual care in pluralistic settings. It is imperative that chaplains do not impose their own beliefs or religious practices on care seekers who have differing religious orientations. While most effective chaplains are those who are firmly grounded in their spiritual and religious traditions, they listen carefully to the care seeker's values, frameworks, and spirituality in providing spiritual care. Chaplains engage in meaning making across cultural worldviews, spiritual and religious differences. They learn to translate in order to support the meaning making. Having spiritual and religious literacy of different religious traditions enables them to both offer particular practices in the language of care seekers' diverse religious backgrounds, as well as build a broader spiritual language and practice that build on commonalities rather than differences. In each of these three ways, the chaplains support the meaning making. The chaplain need to understand their own complex and multiple identities, the bias, privilege, and power dynamics inherent in helping relationships, and limits their capacities when to refer to other professionals. So in summary, chaplains engage care seekers in the spiritual need during crisis or liminal life events to provide care. This ministry of presence, as it has been described, is laden with meaning-making engagements. By considering the descriptive, interpretive, normative, and pragmatic fourfold questions: what is happening, why is it happening, and what should be happening, and what should we do, chaplains help those seeking to alleviate suffering through meaning-making capacity. In these ways, they provide spiritual care by stepping respectfully and compassionately into another's narrative worlds. By mingling the care seekers and caregivers' narrative world, they develop an intersubjective space for meaning making. Chaplains run toward the dying. They run toward the contagious. Chaplain's job is to be present with people in their suffering. Theirs is a ministry of presence. Thank you.
Thank you, Dr. Park, for the keynote speech. For our next keynote speaker, Professor Snyder. He oversees the Master of Divinity degree program in Buddhism and Interreligious Engagement, as well as the Thich Nhat Hanh program for Engaged Buddhism in Union Theological Seminary. Professor Snyder is an ordained Zen Buddhist priest and Dharma transmitted teacher in the lineage of Shunryu Suzuki. He co-founded and is currently the senior priest of the Brooklyn Zen Center, as well as the ancestral Heart Zen Monastery in Milton, New York. Let's welcome, and his topic today is Chaplaincy Buddhist Training in an Interreligious World. Let's welcome Professor Snyder.
Good morning, everyone. Thank you, CEO Lin, Dr. Herr, the Tzu Chi Foundation for having me here, for the incredible hospitality we've received this week, which already points to one of the characteristics of a good chaplain. So thank you. I look forward to learning from all of you as we go through this, because care in our world right now is more critical than it ever has been, possibly. So I want to apologize because technology incompatibility has resulted in the slides animation not working, so these will be quite static. But I want to start by talking about, as we mentioned, chaplaincy and Buddhist training in the interreligious world, and I'll be focusing on the kind of internal training of a chaplain as we deal with it at Union when building the capacities to actually be able to do this. So as we know, we live in a complex, intersecting world where unconsciously relying on commonly held social and religious assumptions has not been an option for chaplains for some time. An inability to open across cultures and religions can harm and fail to provide the support we wish to give those who we serve. Union offers a microcosm. Union Theological Seminary offers a kind of microcosm because we're having to train many people in different religions to work with in a multicultural space. We can't assume that our religious, moral, and cultural presumptions are appropriate for everyone we serve. Not only do others likely orient their beings by way of different religions, they also do so via varying experiences and expressions around race and caste and class, sex, gender, ability, and so on. If there is to be a stable, loving presence in service of others, chaplains must build capacities both to welcome radical and uncomfortable difference, as well as wisely discern within themselves habits of view and behavior that are barriers to inviting all fully into the heart of care. In this paper, the former, the paying attention to loving presence, I'll address through looking at the Brahma-Vihara, which I know Tzu-Chi teach. And as a frame for our affective presence, while the latter we'll look at in terms of karmic discernment. So, hold on. There we go. So looking at the Brahma-Vihara, I'll begin by addressing this as a framework for affective cultivation of chaplains. So as we know, it's metta, karuna, mudita, and upekkha, translated here. The Brahma-Vihara set the stage for grounding human relationship in a deeply held, interconnected dignity and care. While each on its own might prove inadequate, the four Brahma-Vihara together support a whole relationship with another human being. As an example, let us consider, say we're walking past someone who is economically impoverished and living in the street. This is unfortunately quite common in the United States. Committed to loving friendliness, we greet this person as we would our good friend, ensuring we smile from our heart as we pass, sending love with energy, bodily gesture, and presence. However, in this situation, as with many that chaplains will face, metta on its own risks being a shallow form of kindness if it does not fully acknowledge the suffering of the person before us. We then allow ourselves to feel the pain of the person's life, that they are vulnerable, without shelter, maybe unbathed, undernourished, unhealthy, without food, and possibly without family to care for them. This appropriately stabs at the heart, activating a caring wisdom. Feeling the suffering of this life, we act from karuna. Maybe we offer money, food, a shower, a place to stay, or begin to engage local city politics around care for the unhoused. However, even with metta and karuna, we have to further cultivate a recognition of full personhood. We must see the world from another's view, or we risk enacting condescending forms of care rooted in pity, compassion's near enemy. Mudita, or empathetic joy, protects us from pity. Through mudita, we take joyful account of the way this person arranges their limited belongings carefully into a home, no matter how precarious, and we care for their home with them. We inquire into their hopes, joys, aspirations, and meaning in their lives. Through mudita, we resist reducing human beings either to their suffering or to objects of our care. We embrace their full personhood, their perspective, their life, and we find our joy in their joy. Mudita protects us from condescending forms of compassion in the way that compassion protects us from shallow forms of love. Finally, upekkha, or equanimity, is the means by which we navigate the pain of caring for this world. In our minds and hearts, if our minds and hearts are not trained as a calm foundation, relaxed with experience, we will be overwhelmed by suffering, overwhelmed by injustice, even by love and joy. Our life and our care will be off balance. Our care may interfere beyond what is skillful. One sense of responsibility might our sense of responsibility might mentally suffocate ourselves and others, exhausting our bodies to the point that we can no longer serve. Without equanimity, we can too easily become unskillful martyrs, allowing others to be in their personhood fully without our needing to become overly involved. Equanimity provides the wisdom and freedom necessary for the heart to dwell wisely with the other Brahma-vihara. These four together are the ground of the chaplain's sustainable and skillful service. The scenario of the unhoused person translates to those who are sick, dying, imprisoned, suffering from poverty or a natural disaster, or otherwise distressed. In these intense situations, often we are not able to dwell in the Brahma-vihara, and when we cannot, we risk our distress and lack of perspective, harming those we serve. The chaplain's responsibility then is to inquire into what hinders the ability to live from a skilled relational heart. What usually compromises our compassionate presence is, as we know, our self-attached views. Here, view is understood more deeply than just believed thoughts. Views are embedded karmic formations that orient our experienced worlds. The Brahma-vihara are a litmus test for the degree to which we have worked through our unconscious orientations. If I cannot manifest a particular Brahma-vihara, then I do the work of interrogating my views, intentions, and actions to see what hinders that expression. In other words, I become aware of my karma. I am doing something wrong. Hold on, here we go. Within Buddhism, karma refers to moral actions, usually categorized as wholesome and unwholesome. Those actions that harmonize and ease suffering versus those that separate and harm. For the Buddha, the pivotal determinant is cetana, or intentions. So it is not simply the action, for example, giving a gift, that determines wholesome and unwholesome karma, but the intention behind it. Whether we're giving that gift from gratitude and love versus an attempt to manipulate the recipient for self-interested purposes. So in the Kama Sutta, the Buddha describes past and current karma in this way, and this is very important when thinking about a chaplain. And what, bhikkhus, is old karma? The eye is old karma, to be seen as generated and fashioned by volition, as something to be felt. The ear is old karma, the nose, tongue, body, the mind is old karma, to be seen as generated and fashioned by volition, our intention, as something to be felt. This is called old karma. And what, bhikkhus, is new karma? Whatever action one does now by body, speech, or mind, this is new karma. Here we see that past karma is found in our sensory and mental consciousnesses. Our past intentional behavior, what we do via body, speech, and mind, is embedded in the body, shaping and orienting the way we currently see, hear, touch, smell, feel, and think. While not everything that happens to us is due to past karma, the way we experience and respond to everything that happens to us is because of past karma. This insight is critical for anyone in service, as habitual views and actions are likely to be mostly unconscious orientations of the body and mind, limiting our experience and restricting our capacity to relate to others. As old karma is often unconscious, it is imperative that chaplaincy training make the sedimented intentionality of the old karma that's in our body conscious, so we might transform unwholesome karma and be aware of the limited nature of all karmic conditioning. Transformation of our conditioning will be facilitated by three things. Firstly, we accept ourselves as unconsciously conditioned and work not to treat our conditioned orientations as truths. Secondly, we require a cultivated equanimity and discernment that allows us to witness how conditioned behavior regenerates and affects ourselves and others. Finally, we need to consciously devote ourselves to wholesome mental orientations and behavior that counter unconscious, unwholesome conditioning. For example, a commitment to kind, truthful speech that counters habits of judgment and lying. The work here not only replaces unwholesome behavior with wholesome, but to release from all fixed forms of conditioned behavior, even wholesome behavior, if we are acting from self-interested intentions, can cause unintended harm for those we serve. Contextual flexibility, then, is as important as wholesome intentions. We consider self-inflating motives born of attachment to being a good person that can lurk behind compassionate actions and cause us to stumble into condescending forms of care. Non-attachment and wholesome intentions work together to release the chaplain from the missteps of grasping karmic orientations. One drawback, however, to karmic theory as a support for interreligious and multicultural chaplains is that the Buddhist tradition primarily focuses on the individual sage, which alone can compromise our ability to see broader forms of shared social karma. To address this, I will turn briefly to the Yogacara school of Buddhism, which is most known for addressing the issue of collective karma. Yogacara thinkers had to explain why two different people experience roughly the same reality if past karma has shaped the very way each individually perceives. They broadly theorized that this is because groups of people, to greater or lesser degrees, are karmically conditioned in similar ways, which then results in the orientation of skandhas being shaped, our minds being shaped in like manner, thereby resulting in shared experiences. Arguing for this claim, Jessica Locke translates the 6th century Yogacharan Asvabhava to say, perceptions appear similarly to all who experience them through the force of maturation that is in accordance with their own collective karma. This issue here is that the more broadly past shared karma organizes current shared orientations. In other words, if we're all conditioned in similar ways, we're experiencing in similar ways. The more difficult then it is to see these orientations as what they are, which are group biases. The more that individuals are able to confirm their experiences of the world with others similarly conditioned as they are with similar karma, the more they are likely to see those experiences as unconditioned permanent truths rather than karmically conditioned orientations. This in-group confirmation is what makes interreligious and multicultural work difficult, as each group feels confident in confirming their shared karmic orientations as truths, unable to see their perspectives as conditioned. Chaplains find themselves embedded in shared karmic orientations they are unable to see. This embedded karma can even make it difficult to recognize the needs or suffering of others. It is therefore imperative to have a process by which one can illuminate karmic orientations, both individual and shared. Toward this end, we will consider an early Buddhist framework for interrupted karmic cycles known as the threefold training, alongside a class offered at Union that supports the cultivation of alternative methodologies for witnessing and interrupting unconscious formation. So in the Dhammacakkappavattana Sutta, the sutta where the Buddha talks about the Four Noble Truths, he makes liberation from dukkha, often translating as suffering, the work of spiritual practice. After naming multiple expressions of dukkha, the Buddha summarizes its primary cause in the phrase, the 5 self-grasping skandhas or aggregates are dukkha. And these are the 5 skandhas: discerning consciousness, karmic formation, perception, sensation, and form. For the Buddhist tradition, these 5 make up the entirety of human experience. When referring to these aggregates, we are not merely naming the event or process of each one, but the way in which they sediment or aggregate in the mind as they come together in our experience. In other words, each one of these, each aggregate of human experience, is both entangled with the other ones, perception being entangled with sensation and so on, and with its own past impressions. So perception is entangled with past perceptions. They all layer on top of each other and affect the way that we currently see. Our experience, therefore, is shaped by historical conditioning. Mistaking our complex, swirling, interconnected, ever-changing, and highly historically dependent experience for an absolute truth, which is then grasped by us, results in dukkha. It also confuses a chaplain. In addition to this, the grasping of any aspect of experience, conscious or unconscious, is the foundational cause for karmic regeneration. So the seeing of experience as a karmically conditioned event is critical for our peace, our happiness, our freedom, our flexibility, and our relational skillfulness. Wisdom training. Fortunately, the sutta offers an intervention that over time results in freedom from dukkha. Known as the threefold training and eightfold path, it involves wisdom training, which includes right view and right intention, moral training, which includes right speech, action, and livelihood. You all know this as the eightfold path, and meditation training, which includes right effort, mindfulness, and concentration. While the threefold training is traditionally framed here as a means for ending suffering, it can also be understood as a methodology for interrupting, interrogating, and transforming karma. In the Introduction to Buddhist Meditation class at Union that trains chaplains, the threefold training is the underlying methodology for understanding how to engage chaplaincy. So wisdom training reshapes the residual karmic views and intentions through a commitment to dharmic views and intentions. Moral training reshapes unwholesome speech, action, and livelihood with devotion to wholesome expressions informed by precepts, vows, and moral practices. As actions can further entrench their foundational views, meditation training cultivates the mental effort, mindfulness, and concentration necessary to reshape and release from karma. The clearer and more stable the mind, the more deeply our old embodied karma can be felt, penetrated, clarified, and transformed. Our views, both conscious and unconscious orientations, are the foundations for correlated intentions, actions, and behaviors. They relate to each other. The intentions are built on the views, the actions built on the intentions, and then those actions reinscribe the views if they are unconscious. It is the wisdom training, moral training, mind training that brings the Lotus forward, so this just doesn't happen unconsciously for us. The Buddha is quite brilliant in coming up with ways by which we can make these unconscious cycles conscious again. This is very relevant to chaplaincy. Our intentions accord with our views, our actions with intentions, and these intended actions are carried out. They further embed karmic orientations in the body to become old karma, thereby affecting the very way we see, hear, smell, and so on. The threefold training, however, supports us in seeing the conditioned cycle. The harmonization of the threefold training provides a foundation for four important aspects of chaplaincy work. Firstly, one develops a stable, informed, broad, attentive mind able to turn toward one's own habit patterns without falling out of relationship with others that we serve. The chaplain can concentrate both on taking moral responsibility for their own karmic inclinations as well as the person or situation they are serving. As such, the practitioner falls less into unconscious self-attached views, having now the wisdom and freedom to turn their heart toward service. Secondly, once one manifests non-dual, wide, concentrated awareness through harmonization of these three trainings, the whole of experience can be included without the impulse to exclude what is difficult or uncomfortable. We are able to be still, open, and generative with a painful experience rather than compulsively turning away from it. Thirdly, once one has the experience of a stable mind, one can begin to see how unwholesome and unskillful behavior disrupt that stability. The cultivated mind and body become guideposts for moral and skillful behavior. Further, the chaplain is able to deeply sense into unwholesome forms of old karma held in the body. Finally, the foundations of the Brahma-Vihara are found here. If the mind is not trained to aim and sustain in an undivided presence, then the expression of any Brahmavihara is weakened. The practice of the Brahmavihara require effort, concentration, and mindfulness alongside of vigilance regarding one's own karmic hindrances. In turn, Brahmavihara address all aspects of the threefold training, requiring the renunciation of our grasped views, intentions, and moral actions within a concentrated, wide presence of the heart that fully embraces oneself and others. While there are many teachings and practices within the Buddhist tradition that address each of these three trainings, it is important not to insist on Buddhist language and methods. Rather, we develop methods across traditions that support chaplains in cultivating capacities for compassionate presence, alongside taking responsibility for their conditioning that hinders it. So regardless of the presence of taking responsibility for karma within the Buddhist tradition, all chaplains must do this regardless of tradition. So in service of this, we had to create a course at Union that addressed this kind of activity without being focused on Buddhism. While the Brahmavihara threefold training and karma can certainly underpin a methodology for chaplaincy training, Buddhist vocabulary may actually be limiting for some students. This being the case, we've had to find ways to support chaplains in creating methodologies for inquiry into karmic conditioning that do not rely on Buddhist practices. While not everyone is a Buddhist, the need for doing this, as we mentioned, is necessary. So we look at a course that we called the Practice of Self-Inquiry. In addressing the need for all Union students to become conscious of their personal and cultural biases, it became clear we needed to build a language and methodology that was open-ended and adaptive to a diverse group of future chaplains. The aim then could not be the delivery of a particular dharma or religious perspective, but rather the support of students in creating their own methodologies for discerning historical conditioning in order to become more aware of both personal and collective forms of embodied karmic orientations. The course syllabus draws on secular and religious thinkers from multiple traditions for the purpose of developing a methodology for inquiring into each student's own conditioning around self and identity. The course then had to create a methodological structure that guides the student while remaining open-ended enough to include diverse religious and cultural assumptions. The course methodology is organized in this way. So we start off, what is the self? For some traditions, they don't even ask this question. So introducing the question, what is the self? How does the student understand the self ontologically and experientially? Where is it experienced, and what is the nature of what is being located? For many students, they never engage the question. Teleology, what is the purpose of your inquiry? Is it soteriological? Is it about salvation? Is it aimed at pure knowledge, moral betterment? How does their declared aim then affect their methodology for looking at themselves, through which that aim is realized? How are aim and methodology connected? Suspension of a witness. Informed by critical engagement with Edmund Husserl's articulation of epoche, by Zen master Eihei Dogen's backward step, and other expressions of stabilizing a non-judgmental witness of experience, something we're familiar with in Buddhism. What does the students mean for finding a stable witness vis-a-vis their own conditioned experience? Theory of body is a theory of perception. We all have ideas about what our body is, how we look at it, different traditions that inform us. Taking this language from the philosopher Merleau-Ponty, how does the student understand and experience their own body as it relates to the self and experience of a world? The way in which they experience their body has direct bearing on how they perceive the world around them. Confession and renunciation as a process of inquiry. All self-inquiry, in some fashion, requires a form of confession and renunciation in relationship to the aim of that self-inquiry. This is especially the case when morality is centered. For the student, is confession and renunciation then something that is morally normalizing? Is it cultivating some characteristic that they want to see happen? Is it liberatory? in terms of liberating us from self-attachment, or is it some other kind of process? They have to come to understand this for themselves. The scene of address. This is a term borrowed from the work of a philosopher named Judith Butler. And what's being asked here is, who is being addressed in a self-inquiry process? For us, it might be our teacher, it might be bodhisattvas, the Buddha, it could be God, it could be any number of people, any number of beings. So is it an imagined moral other? Is it a communal other? Is it our ancestors? Is it the earth? Is it non-human sentient beings? Here students have to unpack their relationship to their own moral authority. Again, these are being positioned in such a way that they can be broad-reaching and adaptive to whatever in some cases, these students don't necessarily identify with a religious tradition or moral tradition of any kind. So they're being encouraged to take this up. Epistemological method. Is the inquiry phenomenological? In other words, is it about our direct experience with regard to direct observations? Is it rational or logical in method? Does it rely on the imagination or some other method of knowing? How do you discern and articulate the difference as you shift from one means of knowing to another? Reliability of the inquiry. This is inquirer. This is something we all struggle with. I'll go quickly here. But how does one discern and account for the reliability of oneself as the witness, since we are all subject to resistance, self-deception, forgetfulness, and so on? How does one rely on others, spiritual community, elders, authority, as ways of addressing reliability? Responding to resistance. What are the practices that you use to respond to your own resistance and looking at your own conditioning? Social critique. If the I, and this is something interesting for all of us to consider, if the I is a function of norms and conditions, then self-inquiry includes engaging social conditioning and therefore becomes a form of social critique. How is this navigated with clarity? Where does moral responsibility lie? And then directly exposed being versus a narrated self. We all have an experience of a basic, intimate, experiential presence that we know in meditation, that we know in other forms of religious practice. But then there's also the narrated self, the story we tell about who we are, right? How do we understand these? How are they in relationship to each other? How do we inquire into them in their relationships? And how do they support presence in chaplaincy? So I'll just go quickly to the conclusion then here, which is the paper has attempted to highlight two broad aspects of chaplaincy training: cultivating an undivided, compassionate presence, as well as taking responsibility for karmic conditioning that hinders that presence. Practical trainings in mature affective orientations toward others, the Brahma Vihara being an example, not only train the heart in caring presence, but provide a space where any limiting karmic orientations can be illuminated. However, it is also necessary to develop thorough methods for interrogating our conditioning, whether it is the threefold training, a course in self-inquiry, or otherwise, so that chaplains are fully supported in making conscious any unconscious embodied views, intentions, and actions that might limit providing skillful care for as many beings as possible in as many circumstances as possible. What is particularly important here is the way in which our shared collective karmic orientations might be invisible to us, thereby compromising chaplaincy work in interreligious and multicultural environments. In Mahayana Buddhism, we might refer to this non-grasping, non-dual, loving and compassionate orientation in response to suffering as bodhisattva activity. Here we will simply refer to it as the work of a chaplain in an increasingly complex and distressed world. Thank you very, very much for your attention.
Thank you, Professor Snyder. And before we head to our presentation, we have 15 minutes break. So if you're going to go to the restroom or have some dessert, drink some water, now is the time. And we'll have the Symposium personnel to guide you to the restrooms. Thank you. We'll be back in 15 minutes. minutes. We have 3 minutes. Here's a reminder. Now we're going to continue our section for our presenters. So for our first presenter is Dr. Heng-Chia Chang, the Vice Superintendent of Taipei Tzu-Chi Hospital. His topic is holistic healing at Taipei Tzu-Chi Hospital during the pandemic, from healers to Bodhisattva. Let's welcome Dr. Chang.
Thank you. Good morning, CEO Lin and Professor Pak and Snyder and our distinguished guests and ladies and gentlemen. Good morning. I'm Dr. Heng-Chia Chen. On behalf of this hospital, it's my honor and privilege to have a talk this morning. But as you can see, I'm the attending cardiologist, so I'm the clinician. I take my mask out. So my talk is take a different perspective, because I want to share with you during the pandemic what Taipei Tzu-Chi Hospital have been done, and my subtitle is from healers to bodhisattvas. This is a Taipei Tzu-Chi Hospital. Actually, a total of 8 Tzu-Chi hospitals in Taiwan, so 4 in the east, 4 in the west. And this is Taipei Hospital is almost 19 years old, but still is a new hospital comparing to our national hospital, Taiwan University Hospital. They are more than 100 years of age. So, but it's also a beautiful hospital and small hospital. Currently, we're hospital. We put everything digitalized, so it's going to be a new, modern, and digitalized hospital, and it's quite smart. And this hospital is a 1,033 bed. It's a tertiary referring medical center, and we could put on most up-to-date and most state-of-the-art medical treatment for the patient needed. I'm a cardiologist. It's actually in Taipei City Hospital. We are saving lives of critical acute heart attack patients, which is a regular routine of this hospital. And this is this job I've been doing for cardiology for more than 32 years. Yes, and it's gravitating. Especially, I got a letter unexpectedly 4 months when this gentleman went back to New York City. This gentleman had a business trip to Taipei, and he had an acute heart attack, and we treated Thankfully, it's very smooth and uneventful. And 4 months later, I got this thank you card, and he said in the card that your effects and knowledge are responsible for my life. According to the doctors at the Mount Sinai Hospital, I think it's in New York City, yeah. And all the procedures followed by you and your staff were perfect. They said they would not done it any differently. So, of course, this I got this. So we are very happy to work in this hospital. But Taipei City Hospital is also a green hospital. We have a balcony. We minimize the direct sunlight. We have hanging gardens, and it's quite beautiful and it's green. And I want to emphasize what can we achieve during the pandemic, because we designed this hospital in advance. At the very beginning, this hospital is designed as a resilient hospital, guaranteeing uninterrupted health care service in the face of various types of disaster. So let me put it, this is a beautiful hospital, outdoors and indoors, but this is also expense areas is available for handling. If there's a mass casualty instance, we can accommodate a lot of patients there, and we can respond it quickly. And Master Chen, so this is a hospital. During the catastrophic like earthquake, this hospital should be stand still. So it's the first hospital in Taiwan designed for the earthquake-resistant hospital. And this hospital can last for many hundred years, because you see this is the ground, and you will see this rubber isolator, this is a steel damper. Actually, this building is sitting on this rubber damper. So it's separate from ground. So when there's a Richter scale 7 earthquake, this hospital is still stand still and can serve, continue their daily caring job. However, we are also disaster prepared and response. Actually, we have SARS before, and we know there's a MERS outbreak in Korea. And so we are very careful. So long before the pandemic, COVID-19 pandemic, we always exercise, because we know one day, there's always one day, an outbreak might happen in this hospital. So this 4 years prior to the COVID pandemic, this is a drill. So because it's only one flight away from having an outbreak. And so this is the trainer, the trainee, and the observer, and we are very cautious, and we are well prepared long before the pandemic, COVID pandemic. However, this hospital is always something like this. This is a picture in the year 1872. This is outpatient clinic, University Hospital, London. And that's Dharma Master Chen teach us hospital is also a place of spiritual practice, because hospital, no matter old or new, is still a place where people suffer. Yes, every patient in this hospital, they always come here and suffer something. And this is another hospital. Year 2008, March 29th, I went to for a meeting in this National Taiwan University Hospital. And when I passed through this building, I noticed this. And so it's not very clear, so enlarge it. So you can see what the death rate people engraved on this wall. Is in Chinese character, is translated into the English is life is full of hatred and suffering. And this is happened in the Taiwan National University Hospital. So hospital always is a place where people suffer. However, Tzu-Chi hospital are different, because Master think the hospital always plays a spiritual practice. So our Superintendent, Dr. Chao, said this hospital is not built for profit, it's for great love. And so, if you look at this mosaic picture on the wall of every Tzu-Chi hospital, and this is a Buddha's teaching. Then among the field of merit, the merit of giving medical treatment is foremost. So, and then I found it on the west side. This is a picture painted by the Alonso di Sedano. It's the year 1495. And I found these two paints is shockingly similar. Both were taking care of their leg. And this is in the sense Comas and the Dalin perform a miraculous cure by a transplantation of leg of a Moor. You see that? So there's a leg of dream. Okay. And those two paintings will show whether it's an Eastern culture or Western culture. They share the same opinion, because if you provide here medical care, medical treatment to others, this is a healer, and saint may be a healer may be a saint. So even we don't have formal chaplain training in Taiwan, but still, when we are providing medical care, and this is quite a sacred and holy things. And so in Taipei City Hospital, there is a very unique program. This unique program is where a new staff camp. This is a 2-day training course, including one morning section dedicated to cleaning house along with the Tzu-Chi volunteer. And because we wish and we hope that all the new staff, the new nurse, new doctors, and new employees in this hospital would like to know how Tzu-Chi Hospital, the way the Tzu-Chi Foundation, the Buddhist way to take care of the patient. So this is a video show that is a cleaning house along with the Tzu-Chi volunteer. Let's play the video. Okay. It don't have English subtitle, but each one of you will understand what they have been doing.
带着各项生活
They
物
help
资，台北
to
慈济医
clean
院迎新传爱心人谊的伙伴们，在板桥静思堂整队出发，前往关怀户的家中打扫。80岁的奶奶双脚行动不便，生活几乎离不开藤椅，没有能力清扫，
This is
家
our
中随处
superintendent
可见蟑螂的
and
踪
along
迹。
with
大
the
家合
Tzu-Chi
力打扫，
volunteer
将发霉的藤椅
and
换成是具有防水功能的福慧床，医
young
护人员
junior
也关
doctors
怀奶
and
奶的身体
the
健康。
junior
带着学员们进
nurses
行居家打扫
help，
不仅协
to
助
clean
关怀户有整洁的环境，
this
背后也蕴含着深远的
very
意义。
very
知福惜福才能造福。
feels
他们在清扫
house.
体验中流下的每滴汗，陪伴病人，身段也能更柔软。三合院曾经遭受火灾，屋檐残破，室内发霉，地板也有排泄物。
Okay. You know,
学
in
员
a
们
big
不
city,
怕
a
脏
modern
乱，
city
顶着
in
安全
Taiwan,
帽
you
帮
still
忙
have
清扫。
place like
经过
this.
清扫
we
后，
still have
混乱的
people
空间
suffer
清出了走
and
道，
live in
也
such
换了床垫，让邱先
unhealthy
生可以开始新的生
house.
活。
去看卖啊无？
来倒看卖，
来倒一个看卖啊。
倒看卖有素西无？哇，赞赞赞！
Yes, and so because Master Chen's teaching, when others are hurt, we feel the pain. When others suffer, we feel the sorrow. But that's not the end. Then we take action because we want to relieve their pain and relieve their suffering. So what's the Taipei Tzu-Chi Hospital have been accomplished during the pandemic? This is the first case of Taiwan imported from first imported case of a COVID-19. It's the year 2020 in the 21st of January, and this is a woman in Taiwan, but he is got back from Wuhan, China, and right, the first case we found in Taiwan. So we in this hospital, the infection control and outbreak prevention meeting held, and they're chaired by the superintendent immediately, and we were getting ready for the COVID screening station. This is we are well prepared before we actually have a pandemic cases. And this is a different. You know, this ICU room, and it was not qualified as isolation ICU, but we want to renovation of the to be the room and become a negative pressure isolated intensive care unit, so we can maximize in critical care capability. So what we do, what we done during that time is different from other hospital. Other hospital will always say, I don't have the capacity, so I have to transfer to your hospital. But Taipei Tzu Chi Hospital, quite differently, we expansion our isolation room, so we can accommodate more critical COVID patients. And we started to train our staff with a new intubation technique, because this is a safer technique to intubate. And this is quite amazing. You know, in New Taipei City, the population of 4.4 million, there's only 2 operating rooms like this. And one is Taipei Tzu Chi Hospital. In year 2020, we set up an anti-chamber negative and a positive pressure isolation operating room. And it's ready for if there's a COVID patient and they need an emergent condition, like acute appendicitis, acute rupture of the abdomen, and they need a very urgent, very emergent surgery, we can perform this procedure within this operating room, and very safely. And actually a total of, at least, because we still have the COVID patient right now, so at least 118 operations were performed for those COVID patients. So, and this is okay, may I play the video? 25 seconds.
全台湾双北成为重灾区，病例数不断攀升。台北慈济医院重启每日防疫会议，降载医疗服务，设置户外领药窗口与急诊正压筛检站，医护抢救生命义无反顾，行政支援物资，清消环境，开设5间专责病房。
And this is a total of 294 isolation beds and 33 isolation ICU beds.
体重135公斤，
This is a patient
因为
with
血
very
氧降
critical
低，呼吸窘
respiratory
迫，
failure
紧急插
and
管，
shock.
装置
So
叶
she
克
was
膜
put on
抢
the
救，
ECMO.
并接受肺泡再扩张术，吸腹膜过滤洗血。加护病房苏文林主任带领团队全力救治，为患者如诉祈福。
有救了，有救了，太好了，太好了！
1个月后移除叶克膜，护理师陪伴复健，经过56天平安出院。
之后是醒来之后是想念病人，所以就是痛哭一场。病人的生命该救或者是该放手，
真
的是非常困难。不管是在病房病情恶化的，或者是说收到卫生局的求救信。
Tonight
我们都希望说能够把重症的量能能够最大化，能够照顾到最多的病人。
在没有医院愿意收治的情况下，怀孕32周染疫的陈小姐求医无门，半夜紧急送到急诊室。考量肺炎严重，有插管必要。感染科、妇产科、儿科部。 麻醉部与病房护理团队共同讨论医疗计划，与家属、病人进行视讯会议，决定插管后 于具有负压前室的正压手术室进行剖腹产。手术30分钟后，1565公克的宝宝平安出生，母女都平安。
So this is a very touching picture because this is the day this lady arrived to our hospital, and her condition is getting worse, and going to be intubated. So both she and her baby lives were endangered. But this is another day. She had another baby. Both were safe. So this is a newborn baby. We are very happy, and a reborn mother. So we save a family. I only have 3 minutes left. Okay, I will go quickly. And this is a case of congenital intellectual disability. And he was dumped in this hospital because no one was willing to help him. And his father haven't seen his son for 7 months. He was intubated, and regular dialysis are restarted and recovered gradually. And this is our head nurse of the chemo room, went to the isolation ward to assist this patient in bathing and taking care of him as if he were her own son. And finally, we find the patient's father. Okay, this is the photo of the day. On the May 28th, this is our nurse concerned that the baby will be frightened, so she quickly took her out of the ward because her grandma is about to intubate it. So there's a photo of the day. And okay, let me, the companion that comes is Granny.
一名确诊的老奶奶住进专责病房，患有失智及恐慌症的关系，总是用汤匙敲开上锁的安全门。医护团队发挥同理心，合力制作真人比例的充气娃娃，放在病房里陪伴老奶奶安心养病。
好，家属就是告诉我们，奶奶需要24小时有人在旁边陪伴着她。就算不讲话也没有关系，只有这样他才能够安心的休养。所以我们从中间学到，除了正规的医疗以外，心灵的支持跟抚慰也是一样的重要。
Discharged safely. Okay, my time's up, but Taipei City Hospital, we outstanding contribution during pandemic. So this is we rank as a #1. We have been awarded by our welfare department, and we have already published 32 medical papers on the issue of COVID. And so this is my conclusion. And as you can see, during the pandemic, hundreds of our staff, like this nurse, they are willing to take care of those sickest person, and I think I'll be very grateful for their dedication. So it's actually our staff is from healer to bodhisattvas. Thank you very much.
Thank you, Dr. Zhang, for your present. Next, our presenter is Dr. Hwang. Dr. Hwang currently serving as an association professor in the Department of Medicine at the National Taiwan University. College of Medicine holds multiple key positions in the fields of psychiatry with a focus on geriatric psychiatry, psychopharmacology, and expertise in dementia and schizophrenia. Dr. Hwang plays a crucial role in advancing mental health research and practice in Taiwan. And his topic today will be Clinical Buddhist Chaplainship in Medical Service of Taiwan, 30 years of development and contribution by Buddhist Lotus Foundation. Let's welcome Dr. Hwang.
Thank you for the kind introduction. I'm very honored and delighted to be invited to join the symposium. Today, on behalf of the Buddhist Lotus Foundation, I'm going to talk about clinical Buddhist chaplaincy in medical service of Taiwan, basically reflecting the 30 years of effort of the Buddhist Lotus Foundation. The Buddhist Lotus Foundation was established in 1994. Its vision is a pure land of good life and a good death, and its missions are becoming a leading institution for life and death education and a hub for training clinical Buddhist chaplains in Asia, and also actively promote palliative care, spiritual care, and a good life and death education. So with this in mind, we provide 4 major services. The first is Clinical Buddhist Chaplains Training Center. Established this center to cultivate clinical Buddhist chaplains and the spiritual care provider. The second is promoting palliative and spiritual care. The third is grief support. And the fourth is general life and death education. And then you can see basically this is follow the same line from hospice palliative care to life and death education in general. In terms of the CBC clinical Buddhist chaplains training, there's a series of course and the clinical practice. And basically we can separate them into 2 parts. The first part is the primary training. And this is basically after 56 hours of lectures and discussions, plus 80 hours of clinical practice. Then this is for spiritual care providers training. And if we want to become a clinical Buddhist chaplain, then we have the person have to receive another 600 hours of clinical practice. So this usually takes 3 to 4 years to finish the whole course. And right now, this model is similar to medical residence training program. It's a systematized, standardized approach to train CBC. And there are 2 training centers, National Taiwan University Hospital and the Dalin Tzu-Chi Hospital. And currently, there are 39 CBC providing spiritual care service at 47 hospitals around the island. So the slide shows the lecture series about spiritual care. And why do we need CBC, clinical Buddhist chaplains? Because the survey shows there are 75% of the population. They are Pan Buddhist, including Taoism and the folk belief. And in Taiwan, the CBC usually are a monk or a nun, and they are vegetarian, and they are usually very respected by people. So it's very important if they can receive also clinical training and provide spiritual care at hospital or in community. I think that would be very important in terms of end-of-life care and life and death education. This slide shows the training scenario, so including some lectures, discussion, and some clinical practice that is performed at the bedside. And after this series of training, the trainee has to pass written and oral examination, including OSCE, that is Objective and Structural Clinical Examination. That's a model that used in medical residence training. So up to now, the Buddhist Lotus Foundation is the first one to provide CBC training program in medical services. And this is not easy. So over the last 20 more years, we have only trained 72 CBC, in addition to more than 1,000 spiritual care providers. And currently, 39 CBC provide service at 47 hospitals. We also devoted our effort to perform life education training and advocacy activities. And over the years, usually every year, we spend more than 10 million NT dollars in these activities. So this is this slide shows the distribution of the CBC in Taiwan, northern part and the middle part and the southern parts and the eastern part. We are very grateful to those clinical Buddhist chaplains for conducting a lot of compassionate spiritual care, both in hospital and outside hospital. And then later, Dr. Lin is going to share the detail of the training program at the Dalin Tzu-Ji. So the second service is promoting palliative and spiritual care. This including to facilitate the legislation of Hospice Palliative Care Act in year 2000 and the legislation for patient right to autonomy act in 2019. We also advocate for compassionate community. We train palliative care volunteer, and we made podcasts on hospice care. And in terms of grief support, because for everyone die, there are several people in grief. So we also put some efforts in this area. So we developed comforting cards and grief quick guide for people. We train care volunteer. We train campus teacher for bereavement counseling. We lecture on campus grief issues. We also train grief support volunteer who can collaborate with community long-term care center to offer emotional support to bereaved individuals. And regarding the general life and death education, that's more outspread into the community. We have published regular journal, life journal. We make a theme of solo traveling to educate the public about the issue of loneliness and the social isolation about the old adults. We provide life education for different age groups. And we also train in cooperation with local government, that is the new Taipei government. We train community promoters. And those community promoters will go into the community to promote life and death education in community. And we also publish some books. This is the most recent one, which is the most comprehensive one, contain real cases of spiritual care, spiritual guidance, and on palliative care. So this slide shows a summary of the Buddhist Lotus Foundation. 30 years efforts, established in 1994 by our founder, Dr. Chen, and in year 2000 and 2019, we helped to facilitate the legislation of important act, Hospice Palliative Care and the Patient Autonomy Act. And we also has been awarded by government regarding our efforts, Outstanding Foundation Awards, and Palliative Care Volunteer Academy, SNQ. This is a symbol of national quality. And another symbol of national quality is Clinical Buddhist Chaplain Training Center. And most recently, 2 years ago, our founder, Dr. Chen, received a Presidential Culture Award from our president. So we like to say life is the best gift, and the good death is the most beautiful blessing. Thank you.
Thank you, Dr. Hwang. And for our next presenter is Dr. Ming-Nan, the Vice Superintendent of Dalin Tzu-Chi Hospital. And his topic today will be Compassionate Companionship Training Program Enhancing the Capability of Clinical Buddhist Chaplains in Providing Service at Seniors' End of Life Care. Let's welcome Dr. Lin.
Distinguished guests, ladies and gentlemen, it's really my honor to be here to share with you. We cooperate with the Lotus Foundation to have the training program for the clinical Buddhist chaplain. First of all, I want to take the chance to thank Shi Pu An Fa Shi, Dharma Master Shi Pu An, because she is a key person in establishing the training program in our hospital. She is a leading Dharma Master of our clinical chaplain, Buddhist chaplain training at Dalin Tzu-Chi Hospital, and also now assistant professor at Nanhua University, and also she's a supervisor of clinical Buddhist chaplain training program in Buddhist Lotus Care Foundation. And you can see here, this is in our hospital. You can see the symbol. This is a Chinese character is love, I. And then you can see the pigeon here with the English love here. And then there is a heart. And this is a mathematical symbol, infinity. So the love of heart is infinite. It is taking care of the patient is also showing the love to the people in suffer. So we'd like to invite all of you to come to our hospital, in our hospice world, to see what we have done for our patients. And then the practice of Bodhisattva's path in human world, I think that taking care of the palliative patient, the terminal illness patient, is the best practice, the area for us to practice the Bodhisattva's path. Because in the hospital care, this kind of program is like a humanistic spiritual practice ground to provide us to show our love, show the compassion. And then it is the way that we can learn and transmit the Dharma. We get a self-cultivation and helping others achieve enlightenment, 济度度人. And then in the Lotus Heart, we call the hospice world in Tzu Chi is we call Lotus Heart, 心莲. It is training through encounter situation, because here you can see so many people in suffering, and then they will face a lot of problems, physical problems, psychological problems, and also social supporting system, and also spiritual problems. So it is a world that you can encounter all these kind of situations. So you can train through when you're facing these kind of situations. And then from the place of suffering, you can achieve your Puti Xin, Buddha mind. The road to compassionate companionships is we have the training program for the CBC Clinical Buddhist Chaplain, and then through the clinical services, because the CBC Clinical Buddhist Chaplain work with us, the team, with the doctor, with the nurse, with the psychologist, with our volunteer, social workers, even pharmacists or nutritionists. We work together to give a comprehensive services, biopsycho, social, and also spiritual services. And then besides that, we are also praised that we can train the faculty for CBC. And just like Professor Hwang said, that the training program of clinical Buddhist chaplain, we have like 4 steps. The first one, we have a basic course, 28 hours basic level and 28 hours of advanced level lecture and discussion. And then we interviewed the trainees if they are still willing to get this kind of training. So after that, we have clinical leaderships, clinical clerkship in the hospital for 10 days. And then they have to report and pass the exam to pass the primary exam to qualify for clinical Buddhist chaplain training. And after that, they got a certificate for a clinical spiritual care provider. And then after that, if they are still willing to receive more advanced training, we have this kind of advanced training program for 15 weeks, like Professor Hwang said that. And then we have on-site evaluation and training report later I will show you. And then there is the advanced exam. When they pass the advanced exam, including written tests, clinical tests, and also OSCE, and they got certified as a clinical Buddhist chaplain. So totally is 680 hours. And this is a training framework. As you can see here, this is written in Mandarin. The first one, you need to take care of the patient. So in the ward, share care to other hospital ward, and also home care. This is we call clinical services. They have to go with the team to provide services for that. And there is a mentor, the leading Dharma master, the mentor to guide them or discuss with them how to provide this kind of spiritual care. And then we have that teamwork in the ward, palliative ward. Every, like in the morning, there's different kind of activity designed for the patient and their family. And then if they have wishes, and they have that we call 4 thanks, 世道人生, say thank you, say goodbye, say sorry, and then this kind of activities for patients and their families. And then there's so many meetings, so many discussions in the ward, in the hospital, palliative ward. Like we have morning meeting every morning, and we have home care, we have shared care discussion every month. Once every month, and there's we have national teleconference every 2 times a month. There are like more than 50 hospice ward in Taiwan. They take turn to report cases and share experiences, and they have to participate this kind of meetings. And we also cooperate with the Lotus Foundation, have some case discussions. So this is, they have to, just like training a resident. And then the education is like this basic training, because they work in the hospital, so they have infectious control, how to write in the chart, and then the introduction of spiritual care, and then work with, so they have basically with doctors, nurse, social worker, and volunteers. And then the professional training is like clinical, ethical, issues discussion, and then frequent questions, clinical questions like patient have pain or dyspnea, whatever this kind of clinical problem they have to know to some extent, and then how to search the data. If they have some question they want to understand more, we will share with them how to search the database, and then they have to report cases on a routine basis, and then they have to we have we call reading clubs, report to the reading of the books, and then this kind of like live retrospect, live review, and communication skills, empathies, and self-inquiry, and this kind of work is the professional program, just like a resident. So this is, I'll show the pictures. We have routinely every week, so we have a team meeting in the ward to discuss some difficult patients and their families. And this is our head nurse, our doctors, and our volunteer. We work all together, participate different professions' opinion in how to improve the care of the patient and their families. And it's interprofessional training. We have psychologists, dietitian, pharmacists, and then when they have cases, they have discussed, and then there will be feedback. Even in the hospital, this is a Christmas party. The Buddhists also join this kind of Christmas party because we not only for the Buddhists, but also we have Christians, so we also provide this kind of activity in the world. So the compassionate companionship, this is in when the patient is going to die and they want to have the Buddhist conversion, we'll hold this kind of rituals in the bedside. And then when the patient pass away, how to provide grief relief for their families. So we will have this kind of hope visits, not only for the patient, but when they pass away, we also provide this kind of relief, grief relief for their family. Work with the team, doctors, nurses, social worker, and also the chaplain. And we have Buddha Hope in the world. So when the patient is okay, that we can go there for Buddhist conversion. And then I would like to thank Dr. Wang Ying-Wei because they provide these clinical case records. The system is from Hualien. So when they are taking care of the patient, they need to do some written some record, and the mentor will review what they have right and discuss with them how to make a better care. So we have a training handbook. This is a case. The book is published. Professor Hwang has already talked about this book, and also we have this handbook for the training, including all the items I have been shared with you. They have to fill all everything that we need to complete. They need to complete this handbook. This is the first OSCE in Taiwan for medical students, for PGY when they have the bar exam, they need to have passed the OSCE, and then this is the first design to OSCE for our clinical Buddhist chaplain. So they have observer here, 考官, the teacher, and then after that we will have discussion. This is not the national standard because but this is we design this OSCE. What kind of cases, what kind of situation that the clinical Buddhist chaplain will meet. So we design OSCE situation, then they have to practice and then also pass the exam to get the certificate as a clinical Buddhist chaplain. So yeah, okay, this is the slide has been shown. This is examination of clinical Buddhist chaplain. And then we now, not only the 4, but we have more chaplain being trained in our hospital. We can extend the compassion to those in need. Now this is my final slides. If you want to walk fast, walk alone. But if you want to walk for our work together. So we need to have more clinical Buddhist chaplain to serve the people in suffering. I would like to say that our master, Dharma Master Tzung-Jeng is our, our leaders. So we are very grateful to Venerable Master Tzung-Jeng because he created the places, the A hospital for us that we can, provide this kind of compassionate companionship for the people in suffer. Thank you.
Thank you again, Dr. Ming-Nan Lin. So our next presenter is Dr. Ying-Wei Wang, Director of Palliative Care Center at Hualien Tzu Chi Hospital. His topic today is integration of spiritual care into palliative care services. Let's welcome.
Thanks for the introduction, and thanks for having me sharing the experience in Taiwan. May I have my first slide? Because I'm working in the hospice. Actually, we set up the first Buddhist hospice in Taiwan about 28 years ago in East Taiwan. And I'm launching, we can look at the spiritual care in another aspect because we are talking about the chaplain, but actually spiritual care is everybody's business. So look at some of the basic information about the palliative care. We noticed that the quality of depth of care in the globally. There is a survey in 2010. Among 40 countries, Taiwan ranked number 13 and number 1 in Asia. And in 2015, the quality of depth index, there's a comparison between the quality of depth among the 80 countries. Taiwan ranked number 6. And I write a case study. They asked me to say something. Why did we change, improve from number 13 to number 6? Because the community engagement, also the discussion of life and death into the education system from primary school to the university, means that Taiwan started to facing the life and death even in the primary school. There's some discussion since the primary school. And then the most recent report in 2021, and there's among 81 countries. Now Taiwan, the quality of death, Taiwan ranked number 3. In this little comparison, there are another indicator, not only the structural indicators, but also the quality of communication and the quality of care. Among these indicators, including the spiritual needs for the palliative care. So I think that it's really important if we are going to provide our best quality of care, we lead to spiritual care. Also prepare place of death. Also the patient can ask more questions and treat kindly. And this is the definition of the palliative care from World Health Organization. This is to integrate the psychological and spiritual aspects of patient care into the end-of-life care. This is very important. And just mentioned the history in 2017. I have a chance flying from Taiwan to the Vatican cities because they are region of the World Charter Palliative Care for older people. In this time, Tzung-Jeng is coming all together, and we write the charter. We signed on the World Charter for Palliative Care for the older people. So there's a lot of discussion about during the conference from different religions. And the leader is from the Christina Pachaska. She's coming last month to Taiwan and sharing some of the experience about training for the palliative care, not only for the chaplain, but for everybody's. So this is the content, the spiritual and religious perspectives. But just give it this one. And also in the United States, there's clinical practice guideline for quality of palliative care. There are many domains. And in the domain 5 is about the spiritual, religious, and existential aspect of care. That means that if we are going to provide a good quality of care, we need to provide all these domains. But there is also a report. in the spiritual care, in palliative care. They mentioned that although recognized as the WHO as the essential domain of palliative care, but still most neglect component of the healthcare system. That means that we emphasize this is really important, but we still need some more training for the spiritual care. And they start up some of this in the European Association of Palliative Care. They started with so-called spiritual care task force and develop the training, education, and research program. And there's a reference scope and also writing the right papers. There's also sort of core competence of the palliative care physician or providers, and including the competent. There are 10 core competence, and the number 5 is the meet of patient's spiritual needs. So there is still need more training. And in Scotland, in the UK, they think that this chaplain training may be the A levels. It means that this is the highest level. But it should be all NHS staff. Everybody should be trained for the spiritual care. And the B level is those that are taking care of the patients facing death very commonly, just like the palliative care team. So it means that spiritual care should be training for all the 3 levels, not only the chaplain, but also for those taking care of the patient or facing the frontline physician or frontline workers. There's also in Australia, there's a national, Australian national guideline for spiritual care for the all age in aged care. It means that all aged care staff should have some spiritual care training, and also for those with spiritual care professional and also some of the faith representative. This is 3 level also. So this is spiritual care, pastoral care, and also religion care in their proposed training program. So this is the, they said all aged care staff should provide certain kind of education and training. And those with close contact with caring for patients and elderly should provide more training. And also the faith representative has some different kind of training program in their levels. But we also want to mention about spiritual care. Sometimes we use different words. The person-centered care, relationship-based care, well-being, wellness, aged care, holistic care, alternative therapy. All these are related with spirituality. And we noticed that dying is not just one thing. It's a 4 dimension, including the physical, social, psychological, and spiritual. In the past, for those working with the end-of-life care, we almost focus on the physical part. The patient, the condition, the rapid tragedy, just like the cancer, we notice the physical condition gradually downhill. But at the same time, there are some changes of the social decline and also psychological decline, and also the spiritual decline. So this is the thing that we treat the patient as a whole person. We need to look at the 4 aspects, 4 domains of the patient. And from the Lancet, there's different kind of a dying process. One is cancer, the other is organ failure. There's a heart failure, renal failure, liver failure. Also, a really common is the frailty. We notice that this is the 3 different color. One, the yellow color is the spiritual. For cancer, the variation here, and the organ failure, the spiritual care is this line, and also the frailty is almost the same as the psychosocial decline. So when we're facing the patient with different physical or health systems, we have to approach a different approach method. But now more and more people are dying with multimorbidity because of the elderly population. The patient will have a heart failure, frailty, or cancer. So the fluctuation is quite a variation. This is why that the first line healthcare provider should have all these concepts when we're taking care of the patient as a whole. How about the spiritual input for the health professional? I just mentioned that there's a book, Professional Christina Petresca. She's very famous in the United States, I think. She proposed a lot of spiritual training program in the state. And there's a book, Making Healthcare Whole. And they said that actually everybody should take it when we are going to take the spiritual history when the patient admit to the hospitals. As we are working in the hospitals, we notice we have taken the social history, the family history. But now, can we take the spiritual history when they admit to the hospital? This will be a very fast and easy way, but very precise way. Maybe you can just ask questions. What's the most important to you right now? How can we help you? This is all these very simple questions, but once we ask this question, we can take alert of the patient's spiritual aspect. And also there's a training program online. So it's in the professional spiritual training program. She proposed, I have joined this program now, and I've learned quite a lot from it there. And also there's very special report on the national and international consensus. They said spirituality is also a compassion. This is working together, and then the patient outcome, and also for the healthcare professional outcome. The patient feel more satisfaction, and also for the healthcare provider. So spirituality and compassion should be working just like that simultaneously. And not only for the patient, but also the staff. Well, as a staff, we have to create our compassion and self-awareness, and also our professional skills. This is the training for even the providers. So there's a book, I like it. So what I said, talking with patient about spirituality. We translate it into to Chinese, and then we train our staff how to communicate with the patient, talking with the patient, what kind of phrase or response that we can respond to the patient. Let me talk something about our hospice, because we just mentioned while working in the end of life care. This is the painting by one of the volunteers by his mouth, because he lost extremity during the electric shock. And this is the Buddha in the center. And there's two phrases. The heart is like the bright moon, illuminating the purity of the world. And the lotus, as the Buddhist, blossoms the flowers of wisdom over the human world. This is the painting that on our hospice in East Taiwan. And there are many people visit our hospice, and also we always emphasize patient is the center, and everybody around the patient, so we have to serve them. And we have different religions. And for the caring of the patient, actually every practice is some related with the spiritual, because we introduced the aromatherapy in Taiwan 25 years ago. During this aromatherapies, the communication, this is kind of also of spiritual care interaction. And also we have the art therapists. You notice that we train our staff for just using one skill, how to draw a bridge, the bridge. So this is one of the result of the painting from our patient. And when they take draw a bridge, they ask if there are Buddha at the top. If there's the Guanzi Yin in the top, that they can guide them from one way to the another side. So this is the art therapist in the hospice also. We're also doing some of the live review. And live review is also a story, a narrative stories. And the volunteer, also the students train for taking of this live review and story for the patient and the families. And as Dr. Wang, Dr. Lin said about the compassionate spiritual company, compassionate presence, so we have different religions coming together to in the unit. We have some research, local research. Professor she just passed away 5 years ago. He is a very famous clinical psychologist. He wrote a lot of books, studies in our hospice, and it is using the local culture and about the phenomenon of terminal cancer and culture issues, and also about the spiritual care for the patient and art therapy for terminal patients. We have a lot of certain kind of local research on the spirituality. And he always emphasized that we can treat the patient heart to heart, brain to brain, not brain to heart, heart to brain. This is very, very simple, but very important in communication. If the patient says something from their heart, we have to respond with the heart. And this is one of my students doing one of the master thesis in Chengchi University. And the comparison of the hospice promotion film between Western and Eastern countries. As you notice that the Eastern country and the culture, the communication still is not, the culture is different from the Western and the Eastern. We study from the Western culture, some of the video film from America, Canada, British, and Eastern film from Taiwan, China, and Japan, and also mixed culture film from Hong Kong and Singapore. And this is the high context culture. And this is low context culture. Low context from the Americas, Canada. The Eastern culture is the high context. This is being promoted by the Hospice Foundation of Taiwan. When we say that this is the Western culture, this is strict communication. So we have to talk something about the life and death. But in the Eastern culture, we need to, just like the Four Seasons, you have to communicate. You have to say something indirectly with some story before you directly communicate with life and death. And we use this one first and then use this second. And then it's very easy. If you change them, the directions, that would be typical for communication. And we have some of the promotion film from Tzung-Jeng channels talking about the ACP and STM, and we have some pamphlet. For the new movement in hospital and palliative care in Taiwan, we allow, first we have doing the cancer and also the hospital care, shared care. But now we move to the third hospice movement, including the long-term care and communities. And also we propose about the compassionate communities and compassionate cities program in the recent few years. And for the compassionate communities, actually we propose that in Taiwan, also in the East, in Hualien. And there's a 4 dimension about the compassionate individuals, compassionate relationships, compassionate organization, and compassionate communities. And we are now writing some of the proposal on, because we hope that not only dying at the hospitals, but they have to take care at home. Home is the best way that they can stay. So we need a lot of, not only the physician, but also other, because for informal care, in the last year, 95% of the day stay at home, and only formal care, only 5%. And Professor Alan Kennedy said, death is a social event with a medical component, not a medical event with a social component. That's a very important concept that we need to promote the care, promote end-of-life care in the communities. And also from last year, the epidemic of loneliness and isolation, from the Surgeon General in the United States, they said lack of social connection is more highly risk than smoking or drinking or physical inactivity. So social connection is one thing that we need to target in the communities. We show some of the program in the past. Is a training advocates. We have a training program for visits in the training program and also in the hospitals. And we have doing some activity during the ceremony. And also we have a compassionate corner in the Chichi University. We try to educate our students that they have certain kind of concept. And for the Hospice Palliative Care team, foundation from the Hospice Foundation of Taiwan, last year we organized every month their webinar about training for the nurse and physician about the spiritual care, not only for the chaplain, but also for healthcare providers. And this is very important concept that in the past we focused on the blue one is the specialist, but now the generalist and also the compassionate community, and also we have the movement for compassionate spiritual care and compassionate model as a whole. So this is important. We have to kill sometimes to relieve often and to cover always. And Master Teresa said that we can purely cure physical disease with medicine, but the only cure for loneliness, despair, and hopelessness is love. There are many of the world who are dying of a piece of bread, but there are many more dying for a little love. So love is just, I think this is very important. I use your logo. This is my final presentation. Thank you.
Thank you, Dr. Hwang. In the next section will be our panel discussion about the chaplaincy in medical service. And the host will be Professor Rey-Sheng.
Thank you all. It's been very fruitful presentation for this morning. And from the Professor Park to Professor Snyder and Dr. Hwang, Dr. Lin, and Dr. Chang and Dr. Wang. So we had a few questions to raise for our mutual discussion. And also you are welcome to feedback by your own discretions. So the first question is that the mention by Professor Park about the chaplain is wrong toward suffering. And I would like to raise the question is how a difficulty to wrong the contagious suffering, even the dying, right, during the COVID-19. It's a very, very dangerous situation for everyone. Where everyone is scared from the situation, but chaplain have the wrong for it. And I would try to ask how difficult it will be, and what kind of commitment or we so-called resource, the sacred resource, as Dr. Peck mentioned, that will be able to a chaplain to be trained or to be continue their commitment. I would like to raise this question first. Everyone can have your feedback. Who want to go first? Dr. Lin Jinlong, do you want to say something about that? Doctor also wrong for suffering too. If you speak, you cannot mask. It's easier for you. Yeah. Thank you.
Okay. Of course, it's the relationship between a caretaker and the patient himself and the family. It really depends quite a bit on their beliefs. In our institution, the physicians or the medical professionals, the nurses the same, is trying to help or provide the care for the patients. And then the professionals, the physicians, the nurses, or the technicians will feel that is helping, and we do believe, we firmly believe, there is no more blessing in giving than in receiving. With that ideas in mind, you can really get sort of the joy out of being able to help, even in the most dangerous situation that nobody is willing to do it, or the circumstances is such that without the help, the patient's really in isolation, and that requires really the help. Of course, the caregivers itself, even though we are professionally trained, we are supposed to do that kind of work, but individually, spiritually, we still need some type of commitment to our profession. Instead of running away, we have seen people running away from the pandemic because they are human beings and they are afraid of being affected as well. However, it's out of our professional commitment, and I see all the caretakers, providers, I mean, has the same ideas, even providing the spiritual cares, our nuns, our monks, and also our people doing the same. That is the commitment, I think, to for us, is to our profession and our duty to our patients. But others might have different ideas. That's a professional part. As far as the religious area, that's quite different, because what we believe in might not be the same as the patients. They believe in other religions as well, like in Taiwan, we have not many Christians or Muslims, mainly Taoism or folk belief, and some Buddhists. Not really, pure Buddhist is not really that much, because if you can tell, most of our patients are not vegetarian. We had this a survey before. Only about 10 to 12% of our admitted patients are vegetarian. Even though they all believe, or if they say their religion is Buddhism or Taoism, but majorities are not vegetarian. Even though in our hospital, we only provide vegetarian meals, no matter what. But they bring in from outside non-vegetarian items. So there is a gap between what we believe in and what the patient and the family believes in, especially in our hospitals. And that is something that we have to deal with. But the majority of our providers, what I mean is our personnel, including the patients, our providers, including the doctors, the nurses, the technicians, and the volunteers, is under the influence, or at least buying to our principles or the master's ideas of able to provide this tender, loving care for our patients, and they get the joy out of it, even though you can see our volunteers, they are very devoted, and they don't get any name, they don't get any money out of what they provided, but they keep on coming back for some more, our volunteers. And the idea is they get the joy out of this process. So it's a different ideas. The patients and the families might feel differently, but the ideas of our providers, at least, certainly the chaplain, or we have the monks and the nuns will help in that process, because our professionals are busy. They cannot just devote himself all day just to one or two patients. They generally have 10, 15 patients to take care of. So the relationship really are such that our chaplain, nuns, or monks will help in this regard quite a bit, especially in the palliative wards, because that is particularly in need of this kind of services.
Thank you. And Dr. Lin?
Yeah, I would echo our CEO said. I think that is the mandate for clinician or healthcare, what we call medical care providers, because when we face an unknown situation, which is very dangerous, who has been trained to face this situation? I don't think that the general public is the medical care professionals. So if you won't go there to do the services, who is most qualified? Medical care professionals. Yeah, I always think about that. There is a Prof say that courage is not that you face the dangers, you are not afraid of that. Courage is that you are afraid of that, but you are still willing to do it. And I think clinical chaplain is also the same, because that they're trained in hospital. So they have that kind of infectious control training. They know how to protect themselves. So when we face this kind of unknown pandemic, it is a mandate for a clinician or medical care providers, clinical chaplain to do, because clinical chaplain, they're facing the suffering. They're always trained to facing the suffering of people. So when the pandemic comes, yep, this is the time, the chance, they can do their services. So, but we also said that we need to have this kind of training, so they are more qualified to do these services, or who else will do. So I think that it has to think about that as a medical profession.
Yeah, let me add. Taiwan right now is facing the challenges of shortages of medical care providers. The nurses, the technicians, not so much the doctors too, run away from the practice because they are afraid. In such a situation, they have to face. And we close our wards and the operating rooms because we are in a very severe shortages of, this is entire Taiwan. Well,
yeah, I mean, I want to echo both what you both said. And I may just tell a story. During the pandemic, I have a group of people that I teach with, I mean, all the time, but during the pandemic, one of them is chaplain in the hospital, and every day he would go to work, and then when we were having teachers meeting, I will ask him, so he was always bringing news back from the front line. I would say, how many people died today? What did you do? And he would, you know, because if you, I mean, New York City was at the epicenter of deaths and contagion. It was just really worst place in the States. And he would tell us every week where they are in the hospital. One day I asked him, so how are you today? He said, and he could hardly talk because he said, I'm still processing. He said he went into work early. And this is what I said earlier, you know, chaplains kind of, they are in those spaces, they are professional, and they're in those places where you would not necessarily be asked to be in a professional setting. They talk with staff, they talk with patients and families, so they're that kind of middle person that moves through various spaces. So he said he got into work early, and you remember at that time that there are so many deaths, the morgue was full, they couldn't bury them, so they had refrigerated trucks outside, and they were even having like tents where they would bring dead, you know, the cadavers, dead bodies. And that day he went to work early, and as he chats with people who are facility workers, because he talks with everybody, and he said, how are you doing? And he said, so one of the facility workers said, Reverend, do you have a minute? I need some help. He says, sure, I can help you. What do you want? He says, I need you to help me transport dead bodies from the morgue to the refrigerated truck. So he was not trained to carry. He carried 70 dead bodies that morning. He came to work, still haven't processed because he was in the chaplain mode, and he said, I have the imprint in my body. It's not just the spiritual care. He was physically carrying that in his body, and he just started weeping. I asked him, what makes you go back and every day, keep going back? He said, this is my call. And this is something about commitment, and you said that, right? And these are people who committed to run towards that kind of suffering that they couldn't imagine. And then I said, so how do you resource yourself? How do you help yourself so that you're not burned out? He says, in that meeting, that encounter with me and the suffering of people who were suffering, that encounter is so profound that's where I meet the divine. For him, that's where his sacred resources, and that is what regenerates and helps him keep going, because in that encounter, he sees the divine. And I just said, well, that's not something that everyone could do. There are only people who are really committed to that. But I just thought that he wasn't thinking, we're not prepared to do that. And yet, you step into it because he's been asked. So
it's by carrying out those dead body, that's the divine moment. It's really a true Christian and true religious belief. So for Tzu-Chi say that every exercise is a Sangha. Sangha not a place. Sangha is the moment when we encounter with the suffered one. So I think we share the common belief that by those altruistic moments, we encounter the divine, and that's a sacred resource. It's a very, very powerful statement, and thank you, Professor Pak. It's really touching, and I think it's not easy to train someone to really run for suffering. We see the firefighter, everybody, evacuate, but they run into it. And I recall the one priest from Catholic, Damien. He was in 19th century, take care of a leprosy patient in Hawaii. Eventually, he got constructed by leprosy and died in leprosy. But it's not easy, Bodhisattva say, put other first, and then yourself second. But it's not easy. So, from the CBC, I know that Dr. Hwang and many other fellow trained Buddhist chaplain. So, how it's going by training those professionals with the religious belief, especially Bodhisattva spirit. So you want to share your experience to us?
Maybe Dr. Lin can make another comments. And I think in terms of the medical training, the CBC training has two parts. One is medical training, one is spiritual, another is spiritual care training. As far as I know, the medical training part is quite similar to medical residence training. It just see the patient, discuss relevant knowledge and relevant clinical skills and so on. But finally, you have to relate this to a higher level of spiritual suffering, spiritual problem. And I believe during this kind of conversation and discussions, the CBC, the trainer and the trainee will discuss something like what the common spiritual care issues, and for example, compassionate love, compassionate actions, and empathetic joy, and so on. And this is, I think this is reflected not only in Buddha's teaching, but also in Jesus Christ's teachings. So, but I think in terms of Buddha's teaching, there's one thing that's relatively more unique. That is what Professor Snyder mentioned today is equanimity. I think equanimity is one of the four boundless abodes, and it reflects something that is not very secular. It's beyond usual sensation and perception. And if we can practice some meditation or related Buddhist practice, then maybe we can have the opportunity to have a touch about so-called equalities. That is a selfless conditions. And this kind of condition usually let us feel that when we saw a patient, when we see a patient, in fact, we also see ourselves, because this body actually is a misperception. Is this really so-called I? In terms of psychotherapy, we say this is ego. Ego is an identification of body, sensation, thinking, and emotions. But we know that beyond these three domains, body, sensation, thinking, and emotion, there's another part beyond this. And that is a condition. And if we have some kind of meditation experience, sometimes we can experience that. When we sit very still, we can feel the body just disappear, and your thinking stop, your emotion stop. And at that time, there's awareness. And this kind of awareness reflecting our being and not our doing. So this is what I think something that may be discussed during the practice. And I think there are a lot of issues, but on the surface level, they are very common. Component across different religions: love, compassion, and empathy, and so on. But there are some kind of unique component that may be more discussed in Buddhist chaplains. Thank you.
I think the Professor Peck mentioned the moment that the Reverend tearing, and yet she or he still have a strong spirit to face that situation. So this is like compassionate pain, but also come with strength. This is very important for chaplain training, I think, and for the spiritual chaplain. And I think he deserves to more effort to cultivate this field. How altruism provide the inner strength. Instead of keep a distance of your emotion as a journalist or as many professionals, not only journalists, even doctors, even lawyers, they keep distance from the object. But for the chaplain, it seems like you have to suffer their suffer. And yet, by those compassionate suffering, you accumulate your inner strength. So tearing and compassion and compassionate pain and inner strength join together at the moment. This is a very, very fascinating point. And I think it deserves us to have a more cultivate this field and put more effort on research on that. And the second question I would like to raise to all of you is that provided by Professor Snyder about the group bias with so-called collective karma. You know, as Professor Park saying that as a chaplain actually is a meaning maker. We reconstruct the meaning to an individual so that they can transcend their spirit from those suffering, physical or spiritual, from sickness or dying situation. So to change individual bias may not be easy, but change collective bias is more difficult, more challenging. So how can we do that? So Professor Snyder want to say more, and probably everyone can have a feedback about that. Collective bias is it's invisible, and you will take it for granted because everybody says so, right?
Yes.
So why I'm different, right? So it's just not easy to transform these collective karma or collective bias. Thank you, Professor.
I thank you very much. I'm still having thoughts at the last question, so I'll shift to this. I'll say one thing about the last question, one quick thing, which is once we make the Bodhisattva vow, which I think is the chaplain's vow, there will never be relief in the sense that it's never going to end. We're not going to have relief from the outside. Suffering is not going to, there's not going to be the moment in world life where we're not dealing with something we have to address. So one thing that we say is because of that, we have to ensure rest. Like if we want to keep coming back to something, and I think for communities that are so committed to the Bodhisattva vow, rest is sometimes underappreciated. So I want to say that in equanimity and meditation, I agree with Dr. Hwang completely that there is this sense that our freedom from taking on so much suffering, we need to cultivate an equanimity so that we are not dragged down by that pain, but also our bodies and our hearts need simple rest sometimes so that we can keep continuing back. But we have to encourage each other to do that because all of us are looking at the pain and saying, I can't stop. I have to keep going. But if we keep going, we'll get sick. So I want to be very practical and say, let's all of us encourage all of our fellow bodhisattvas to pay attention to our hearts, minds, and bodies so that we rest appropriately so that we can keep running back towards suffering. Because we're in it for a long time. So in terms of collective karma, it requires us to examine anything that we feel is a truth is what we must examine the most thoroughly. That's usually the thing that we share with other people, that people tell us. If we think it's a truth about the world, then that is the thing we must interrogate the most thoroughly, because that will trip us up. And so and of course, if I'm in the middle of a bunch of Americans and we have beliefs about the way the world should be, we're wrong. Or it's not a matter of right or wrong, but it's narrowed, it's limited. We're conditioned in a certain way to agree. So what Tzu Chi is doing, I said to Dr. He earlier, is I think what Tzu Chi is doing is important, which is to bring together different cultures in dialogue with each other, to begin to actively challenge what our cultures hold as true. One way of talking about this is cosmopolitanism, right? The whole idea of bringing together people into conversation with each other and saying, oh, that position makes me uncomfortable. If that position makes me uncomfortable, then that gives me a pathway to looking at my own and saying, what am I holding on to? Because if you speak, I can say, that too is me. And if you speak, I can say, that too is me. And if you speak, I can say, that too is me. And keep going around the table and include everyone's perspective as me. But if there's one that I go, ugh, that's not me, then I have a moment to look. So I'll stop.
I would also like to share. I think that a couple of years ago, one of my friends said that your friend is just a people who buy in your bias. And your good friend is the people who buy in most of your bias, right? But I appreciate Professor Snyder said that we believe in Buddhist in action, Buddha-Sava way. So we want to democratize our bias. Yeah, this is the way that we democratize. Yeah, we use a democratic way to get more people to buy in our bias. So the collective bias is also the way that we want to extend the love of Bodhisattva, the way, the path to relieve people's suffering. Yeah, I think that also our Dhamma Master Tzung-Jeng said that have to do this way to relieve the suffering of the people, and then we democratize our bias, and then we have more and more people enjoy our bias, believe our bias. It is collective karma.
Human beings have a strong tendencies to bring everybody just like you. So that's why the conflict come from religion, come from nationality, come from different ethnic. We hope that everyone recognize us and agree with us, and we have not learned to accept the differences. That's big trouble, for the human brain and human spirit. So we have to learn to escalate in the human civilization to accept differences and tolerate the differences. But it's not easy. But do you want to provide any practical experience when you run into someone have occupied by the prejudice or bias, and that is suffer from that, and you will be able to employ your professional skill to be able to relieve their bias? Have you want to share all your practical experiences for that? As a chaplain, say. As a chaplain.
Actually, in my clinical practice, that is a psychiatrist. We face people who has a lot of different kinds of preoccupation or even delusions. So that is the situation that we have to help them shake this kind of false belief. But it's not very easy. From my point of view, when I saw a patient with schizophrenia or delusional disorder, we think he or she has a firm belief, a firm delusion. But when we see ordinary people, I find that most people also have some kind of delusional-like. For example, everyone share that the belief, tomorrow I'm going to be alive, right? Never people say, I'm going to die tomorrow. So, but I think this is understandable from evolutional point of view, because evolutionarily speaking, we want to continue our species, continue our living. So I think your question is a very difficult question, because basically, biologically, we are kind of determined by the evolutional force. So we have to stick together. We have to marry. We have to have children to make the species continuous. And by doing so, we form a society, we form a family, and we share many opinions. We compromise each other to reach some kind of delusions. Probably we can say that's also a kind of delusions if we are open enough. For example, in human beings, we can eat meat. We sacrifice animals' life for our appetite. But if animal can say something, they would very object to this kind of concept. So I think from biological point of view, human being has a brain with a large part of frontal lobe. And this kind of frontal lobe is responsible for abstract thinking, for moral thinking, moral reasoning, and this kind of thing. So basically, to be a human, I think we have the opportunity to rise above our animal propensity, and to see things just beyond ourselves. So in our clinical practice, I think it's not very easy. But first of all, usually if we want to change the patient's delusion or some kind of overvalue ideation or preoccupation, the first thing to do is to accept his or her concept, not resistance, and to establish the relationship. It's better to be a trustable, loving relationship. And after that, then we have the opportunity to propose another point of view. Yeah, that's why I think.
Okay. There's one psychiatrist called Zheng Ruose. You might know him. He's my good friend. I was a reporter and I interviewed with him. He said many schizophrenia patients have a delusion, so it's not Tao Temple to bring them delusion, because they have delusion first, so they're seeking for the Tao Temple to rationalize their delusion, because no one can accept that. So the thing is for the chaplain is that you remove the delusion, or you by accept their delusion, or by using the delusion to comfort them. Because from a philosophical point, we heartily define what is normal, what is abnormal. I think it's very different from people to people, right? Because I'm study philosophy, so I have asked the philosophical question: is that by using their delusion to comfort them is the purpose of chaplain, or is your purpose to remove the delusion? Which one is a better one, or can be both? Okay. Well, you can say whatever you want to say. Dr. Chang, yeah.
Another question.
You can skip my question and respond your own answer, yeah.
I want to echo Professor Hwang's, because for human nature, the high cortical function, people's behavior mostly are irrational, right? Because the neural pathway from the high cortical neocortex to limbic system, the projection, we are all mostly controlled, or we have control by emotions. So it happens in our daily practices. Because always we have to persuade our patients, you need to quit smoking, you need to eat healthy. So this is always the daily practice, but it's not easy to change the behavior or the belief of the patients. So Professor Hwang said that we need to accept, so to build up the therapeutical alliance. So we have been trained as motivational interviewing skills, how to change the concept to improve the health of our patients. But now they have their different value. Everybody have different values. So we have now shared decision making, because we respect. And then, but we need, because of the training professions, we are the healthcare provider. So we want our patient to stay healthy, to quit smoking, to exercise regularly, to eat healthy. So, but we also need to respect. We don't force them. So use of democratize. I like this words. Democratize our bias, our training by training, and then try to persuade. But if they won't follow us. But we need to train our ability, our competency to do that. Yeah.
Yeah. I mean, this is so interesting. Thank you for that. So this is more of a personal story related to this. Is when my mother was diagnosed with Alzheimer's, I was talking to my colleague who is a Jungian therapist and a professor at Union, and I was telling her, talk about delusion, and this is not the real world, right? I said, well, this is the real world, and what she's living in is not real world. And she looked at me and she said, go into her world. It's infinitely more interesting than yours. So I thought, wow. So I did. And this is to your point, right? My relationship with her and caring for her was about stepping into her world and not force her to be in my world. And I think I talked about the narrative paradigm where the chaplain and the care seeker are sharing and entering the world of the narrative world of the other is so important, whether it's for temporary purposes or for building therapeutic alliance or providing care, or, and I would ask, do we ever need to come out of that world? I don't know. I mean, I would ask that. I don't know. But can we stay in that world and still provide, alleviate suffering? And I would say yes. But is that the goal? I don't know. So I just would love to, this is such an interesting conversation.
I think that the key word I heard today is about the meaning and connections. As you mentioned that you're going to her word, there is something meaning in her word, and also the connection in the past. So I always encourage my colleagues when facing with the patient, just understand the meaning and then with the connection in the past. That will help them. And we don't want to impose our idea on the patient, and also accept their present situation. Sometimes there's a change very frequently. And as Professor Yu, I just mentioned the scholar, the clinical psychologist, he told me that when we accompany with the patient, just like dancing with the patient with tango, but the patient leading our steps, we follow them, follow the patient, and once they are free to move, they are free to choose their feeling or thinking. But once they need help, we stand by themselves. They can call us. So just like dancing with tango with the patient during the spiritual care. I think that is very important, that letting the patient in our word, but not leading us, but not impose our feeling to the patient.
Actually, I have a question and another issue. You know, this topic of chaplaincy, medical service, because we want to help our patient because they are vulnerable. But actually, our staff, they also vulnerable, especially in the pandemic. And Dr. Lin, we both are cardiologists. We know so many years, many junior doctors, when they want to become a cardiologist, they cannot stand for it because they cannot face the stressful event. And once their patient is dying, and they collapse. They may indulge in drug or alcohol abuse. So actually, I think chaplaincy may also help for our staff. And that's quite true, because we are losing our medical staff, and they live for they're looking for better, easy job, and they are not going back to the especially the critical section, because they are vulnerable, and they cannot handle with us. So chaplaincy may be helpful, I think.
That's very true. That's very true. Yeah.
Not only the patients and the families, but the care providers needs help as well. Otherwise, they get burned out, first of all. They get burned out. It's so much work. And they get depressed with so many diseases and death going on. They really, mentally, they need help. So chaplaincy, not only for the patients and the families, but for the care providers as well.
Just during the pandemic, most of the work that's done by the chaplains were working with doctors and staff, because they couldn't be in touch with patients and the family were not allowed to be in. The only contact they had with the family is over the phone. And you know, the person is dying, they had to put the phone, and everything was all barricaded, right, because you couldn't go in. And that was the only way that they were able to help communicate. But 95% of the work done by the chaplains during the pandemic was with doctors, nurses, and staff. So you have a really good point there, yeah.
Professor Snyder?
I was going to respond to about using the delusion, you know, and it just made me think of our tradition, right? Because in the Western philosophical tradition, there is this notion of there is a truth and you're always better if you know the truth. But in the Buddhist tradition, that's not the case, especially the Mahayana tradition, not in any way. Any grasped belief is delusional. right? Any grasped belief. So if we're sitting there with like, we have the correct view and they're delusional, well, we're delusional in that moment. So the question then doesn't become truth or not truth. I think the question for Buddhists becomes, what is wholesome and skillful in caring for a person's life, and what is not wholesome and skillful? And sometimes what is wholesome and skillful might be a view that sounds crazy to the rest of us, but it's actually what takes good care of them in that moment. So I think to have a mind and a heart that is flexible in that way is really important to love people. Yeah.
Yeah, Dr. Hwang, yeah, continue.
Yeah, I agree with you very much. And I also want to say...
Have you turned on your microphone? At the bottom is like a transmission, so hold your microphone upper part.
Yeah. I want to share with you another point. In fact, our chaplain, our CBC also tell us they are vulnerable too. So when they face, when they face this life situation, life and death situation, sometimes it's also very painful, and they have difficulties. So then we have to have a social supportive group for them. So that's why we conduct regular meetings to share experience among the group and support each other. So from this point of view, social activity is important. It's also important, and everyone have to face the real life situation, and then there is no need to be always strong enough. You can show your weakness. Yeah, I think that's a very natural thing. We all limited by our body, by our limited energies. Yeah, thank you.
May I ask questions to Professor Park? Because as far as I know till now, that we provide the spiritual care services in the world, in the community, but you mentioned about in the airport, in the acute situation, but it takes time to build up relationship, right, connections. So I'm wondering the role of the chaplain in acute care situations, like in the airport, maybe some disasters, or can you share with us how can they play their role as a chaplain in the acute situation?
Generally, chaplains are always, unlike a religious professional like a priest or have a sangha, there is an ongoing relationship. Chaplains are usually in a situation where it's one-off. In the hospital setting, you may never see another patient once you've seen them, because they may be there or they may not be there. I think there are situations like hospice, which is longer. You have a time to build relationship, but the training of a chaplain is exactly crystallized form of suffering, right? So crisis. That's how they're trained to think, in terms of, you might never see this person again. You have one shot at it. How are you present to alleviate suffering? That is sort of the difference between being trained as a religious professional in a community, in a sangha, versus a chaplain, because that's how. So it's like you are stepping in there with totally open mind about what the person will need, and sometimes they can't communicate, and you know what? It doesn't matter, because it is about showing your presence, and this is what they call it, a ministry of presence. So it's actually more of an unusual situation that a chaplain being trained will have a long-term relationship with the care seeker. So that would be, in the airport situations and other places, I think the airport is not necessarily when there is a crisis. Airport is people are traveling, and you have a layover, 3-hour layover, and then you feel stressed because you're going to miss the flight, or the traveling always gives you anxiety. There are chaplains at the airport providing care just to listen to their stories and alleviate that anxiety. So it's not just in the crash situation or disaster situation, but in a less pressured settings, but still be able to make that connection for the people who are seeking care.
Okay, Dharma Master Tzung-Jeng. Please hold your microphone upper part. 你把麦克风往上握，你现在往上握麦克风，对。
It's okay. I'm a clinical Buddhist chaplain, and I try to have echo on Professor Her's question about delusion. Many years ago, one morning, a patient come to my office and tell me, I get confused. There are two eyes. I feel two eyes, two levels of eye. One is up, one is down. Who is really I? And I think it's maybe we say it's delusion or Wang or delirium. And we know when patients from life to death in a terminal process, in Buddhism, we have a theory about 4-element dissolution, about death, earth, 地水火风, earth, fire, water, and wind. And accompanying with this process, a patient will have different feeling and they see different things. And the chaplain's task need to talk with them, to have conversation with them, what is really. And there one thing very important is Dharma practice. Dharma practice, it will help us to calm down and to have peaceful experience. And it's according to the teaching of Buddha, or according to the teaching of Christianity. I think it's common. This is my point.
So, as Professor Snyder mentioned, that for the Mahayana Buddhism, we believe that we have to abandon non-dharma, but we have also transcend dharma, give up dharma. So we are not have hold up some certain truth. Well, this is a Buddhism philosophy. But for the Christianity, the chaplain for the Christianity have different belief, or we have a common ground of chaplain, no matter it's Buddhism, it's Christianity, or Muslim, or Judaism. Professor Pack.
So the belief of the chaplain is important that they're grounded in their own tradition. But if we're tangoing and the care seeker is leading the tango, then we are open to the way they express their religious belief. But I could only make sense and make meaning for myself as a chaplain within my own tradition. But that's the skillfulness, right? Is to face and let the person who's seeking help lead the tango by entering into their world by entering into their religious, framework and language and practice and ritual. So that's, like, so the skillfulness of the chaplain has to know those translations. But I think that's common across all chaplaincy, is that, yes, be grounded in your own tradition as deeply as you can, because you'll need it for your own resources and the way you understand what's happening, and be totally open to being led by the one who is seeking help and not you're leading with your own. And sometimes it doesn't translate so well, and that's a challenge.
And I sometimes I believe that is gifted to healing others. It's not easy to have a spirit like this. So do you believe, or you believe that chaplain actually can be trained, or somehow is quite gifted? So what kind of person could be a good chaplain? Or everyone can be a chaplain? You know, of course, a volunteer, they accompany with those suffer one in a disaster side. Well, they are not chaplain, but somehow they can be a good, very good companion for those suffer one. But that's my question: is who can be a chaplain? Is that gifted, or can be trained, or to what extent it can be trained? Maybe the final question may be a difficult one.
That's what is it, nurture or nature question? That's an age-old nature-nurture question, and I would say a bit of both. I'm going to take the middle path here, okay? All right. I don't think everybody has a stomach to be the chaplain, and that's okay. But everybody can provide relieving of suffering wherever they are without calling it a chaplain, right? I think when we talk about chaplain as a profession, there is a certain things that we expect them to step into. If we're talking about who gets to provide care when there's care needed, everyone should be able, that should be our calling, that should be our life, right? But I just want to distinguish the professionalization of chaplaincy. And I would say, can everybody be a doctor? Or is that, but everyone can heal, but they can't all heal in your way or your way, right? So I think it's a similar question about how we democratize certain kind of knowledge or role, whether it's healing or whether it's providing care, and specialize in terms of professionalization. So I would say both and. That's cop out, I know.
One can care, but some of them can be chaplaincy. It can be chaplain. Okay. And I remember the Dr. Song told me, comfort always. The cure is very rare, very rare. Yeah. Okay, yeah. Dr. Lin.
I would like to share the same thought about hospice care. So we have a hospice ward, right? But when we train our psychologists, doctors, nurses, but in the hospital, every ward can provide palliative services to some extent. But when they need more resources, they need more professional care, they just like transfer a patient to ICU. This is spiritual care ICU, because we have chaplain, we have skilled nurses, we have a doctor know about how to reduce their symptoms, use morphine. So this is a special care. But everybody, every healthcare professional in the hospice, in a hospital, need to have some kind of concept, because not every patient need this kind of services to that extent, like in ICU. But like in our hospital, our resident in internal medicine, they had to be trained in our ward for 1 month. In ER, their resident need to be trained in our hospital for 1 month. They just have some concept. They can provide basic services as palliative care, but they know when their patient has that kind of situation, they need more intense care of hospice. They can know when and when to transfer to our hospice wards. So I think that is, as a family physician also, we are trained to take care of most of the diseases, most of the health problems, but we know when to transfer, to refer our patient to the specialist, but we provide most of the services, qualified services.
Okay, I think we have a very productive discussion this section, and we're looking forward to more collaboration between the Tzu-Chi Hospital, Lotus Foundation, and the New York Union Theological Seminary. We are definitely looking for this kind of cooperation by exchanging our view or student or fellow, and especially I appreciate very much Professor Peck and Professor Snyder, and also Mrs. Snyder can join this discussion and come to visit Tzu-Chi. And thank you for Dr. Hwang, who invite all your members to join this dialogue. Thank you so much. Thank you.
So, on the behalf of the Tzu-Chi Foundation and the Theological Medical Foundation, we have some small gift for the presenter and the keynote speakers. So we invited CEO Junlong Lin to give us some gift. So, for Professor Peck, thank you. And Professor Snyder. Also. So Ying-Wei, Wang.
For every speaker.
Also, Laura.